who's gathered here. So on behalf of the staff and management of Dr. KK Surgical and Pediatric Center, I extend a very warm and heartfelt welcome to our chief guest, eminent guest, and guest of honor. I request Dr. Prashanthi to accompany Dr. Nirmal Frederick to the dais. I request Dr. Indumati to accompany Dr. Kasi sir to the dais. And I request Dr. Soundram to accompany Dr. Chitra Ramamurthy to the dais, please. Once again, a very warm welcome to our chief guest, Dr. Nirmal Frederick, the president of Tamil Nadu Ophthalmic Association. He's the author and chairman of NABH Eye Care Standards. He's a chief eye surgeon and MD Nirmal Eye Hospitals. His unwavering quest for quality, commitment to good health, and dedication to financial freedom for his fellow members is truly inspiring. He has been a fervent supporter of budding young ophthalmologists, always ready to lend a helping hand. Sir, we fondly remember organizing mid-year TNOA under your able guidance. It was an experience where we never felt the burden and enjoyed every moment. Your knack for delegation, automation, and simplifying complex tasks is unparalleled, just like a magician who makes everything look effortless. And next, I'm delighted to welcome our eminent guest, Dr. Kasi, who's the Vice President of IMA Tamil Nadu North Zone. He's a staunch advocate for the rights of the voiceless and lesser privileged sections of society. He is also the Secretary of Doctors Forum for People of Tamil Nadu. Personally, I often refer to him as Google Map. You may ask why, because he never questions your decisions with a why did you do this. Instead, he guides you, do it this way and now. He has a unique way of criticizing when things go wrong. Instead, he directs us, finds alternate routes to solve problems and troubleshoots without a hint of criticism. So I welcome our own director and our eminent guest to this CME. Next, it's my absolute pleasure to welcome our distinguished guest, Dr. Chitra Ramamurthy ma'am. She is an evergreen and ever-enthusiastic person, a pioneer in the field of cataract and refractive surgery. She was a past ARC chairperson of AOS, now president of Coimbatore Ophthalmic Society and director of Eye Foundation chain of hospitals. She has adorned many posts and chairs and has contributed a lot to the members with great commitment and dedication to AOS and TNOA. Her dedication to her field and her remarkable achievements are a testament to her commitment to excellence. So, and her unwavering zeal to embrace cutting-edge technology knows no bounds, and her passion for surgery is so profound that she often jokes she will continue to operate until she drops down. A very down-to-earth person, always approachable and ready to share her experience and expertise, and we are truly honored to have her here today. So, with such esteemed guests and an exciting agenda ahead, we also welcome our eminent speakers, Dr. Kasinathan sir, Dr. Nishant, Dr. Shreyas Ramamurthy, Dr. Soundram, Dr. Seema, and Dr. Arvind Venkatraman, who will soon join us. And Dr. Vanaja has said she had a compelling family commitment, so she couldn't join us. So welcome all the speakers and all the delegates. Now I request Dr. Nirmal Frederick, our chief guest, to address the gathering and then inaugurate the CME.
Thank you, Dr. Kavita. And it's that, friends, it's an honor to be here today at this CME, ever-evolving refractive surgery. So this is one field every day there are changes, every day there are new machineries coming up, new innovations, new technologies, and it's indeed a good gesture on the part of KKI Hospital to organize this meet. So I would like to take a moment to thank and acknowledge the remarkable contribution of Dr. Kavita Lakshmi. Her brilliant academic career, coupled with her immense social contribution along with her husband, Dr. Kasi, and now entrepreneur journey. This emulate is quite difficult to emulate and learn from. I've observed her as contributing member of IMA Tambram, as well as the last term as Vice President of IMA Tambram, contributing to the academic milieu. And now as the President of Tambram Ophthalmic Society, she has wonderfully organized the mid-year meet, making TOS a vibrant society under her leadership. And now this is a new way or introducing a refractive suit to Tambram. She has added another dimension of entrepreneurship where people really find it tough to take a decision whether to enter this arena or not because of the huge cost and commitment involved. So it's indeed a bold step for bringing the entire refractive suit to the Tambram. I think this is the first in Tambram area. So give her a big round of applause and support for this entrepreneurial journey. I'm sure it will be a great success like the other things she has started. She's not only an academic clinician, but also possesses a stable hand as a surgical surgeon par excellence. We have seen wonderful results from her practice. I'd also like to appreciate Dr. Kasi for being the Google to her. And I also want to ask Kasi to share the secrets, how to get appreciation from the wife on behalf of all the married men here. Kasi, I think you should give a talk on that. I'm happy to be with Dr. Chitra, again a charming and dynamic lady from Coimbatore. Many academic honors to her credit. She's also a pioneer in refractive surgery, and I'm sure her presence here will add to the academic milieu. So being part of this, thought not bore you too much because a long list of wonderful speakers here. I'm eager to listen to them. But three important C's. In cataract surgery, we start with C, three C's, Rex's, CCC. But here in refractive surgery, I think these three C's are important, particularly from the entrepreneur point of view and the practice point of view now. So one is collaboration, because this is a very costly and very dynamic field where a lot of resource, I was talking to Dr. GR sir, asking what is the cost and whether it's very difficult to maintain or manage. So this is not only cost intensive, but resource intensive. You have to maintain the machine as well as men and the atmosphere in which it kept and manage for a long time. All this brings in huge investment and cost. So most of the LASIK centers or laser centers are operated as a collaborative unit. And this is where this particular field brings all the people together, right? So what the profession could not achieve, this particular specialty achieved, because across the country, all LASIK centers are mostly group practices, right? So particularly if you go to North, most of them are group practices, hundreds of surgeons operating under one unit. I have the opportunity to visit most of these laser centers, wonderfully managed. All of them are either private limited companies or group practices. And I was surprised how this field can bring together people, right? Of course, money brings people together, but other than what we see is the competition and practice jousting. But in refractive field, the collaboration has evolved and has really done wonders to our field. So hopefully this unit in Tambram will bring more collaboration to bring people together. And the second one is the costing. We are indeed fighting a long battle with the insurance companies now. So when we do costing, let's not cut cost, and to maintain quality, we need to maintain optimal cost. And particularly refractive surgery being very, very cost intensive, we have to maintain that because the outcomes are really important and outcome cannot be compromised for cutting the cost. So there's a huge competition, but I'm sure this costing factor will be taken care to maintain the image, brand image, reputation, as well as the sustainable pricing structure. Because if we reduce, the beneficiary is not the patient nowadays. The beneficiaries is the third-party payers, and they induce a lot of competition among us. And in the process, next to the government, so government takes 40% of our revenue. But the third-party payers now demanding 40 to 50%. That's more than the government share, right? So this is where we have to be really conscious about the costing factor, so that not the third-party payers, but the community will be benefited. This is the third C, because so this is one field that is considered as premium, high premium, but I think the benefit has to reach out to the community. So if we are able to provide this direct benefit to the community in whatever we can do, we can certainly survive in this highly evolving refractive surgery services. So with this, if we focus on these principles, I'm sure your entrepreneurial journey and our collaboration will be a great success, and wish you all the best. May this be a fruitful and enriching experience for everyone, and wish the conference all success. Thank you, Kavita.
Thank you, Dr. Nirmal, for the nice words and words of wisdom. I now request Dr. Kasi to address the gathering.
The outset, for your nice words, and I will not take it openly. I will tell you later. And it's highly rewarding to get a compliment from our own life partner. That too, in a gathering like this, it's a mixed gathering. And also, I always support her in all aspects of life, for maintaining the work-life balance, and also for maintaining the high academic profile, also maintaining peace in the family. And ophthalmology is an ever-evolving field. Every day, it rapidly expands, and also we have to update every day. Otherwise, we'll be out of field. In that way, ophthalmology is unique for me in two ways. One, it is the field which evolves faster, and late it's made us gentlewoman specialty too. I think because of my position as Vice President of IMA, I am given this honor of being the eminent guest here. At least, I think at least for this reason, I have to hold some of the post always, to get the compliments like this from Dr. Kavita. That is one of the secrets, sir. And next, our chief guest, Dr. Nirmal. I met him 2 decades back in 2002-2003. When I met him, he was a man of few words and very humble. Now also he is humble only, but very humble and uh, now he is the most sought after leader of your specialty and also our field, our IMA Tambram. And he can talk, now he is talking in every meeting, in every aspects of life, as well, particularly the standards of medical care and ethics of medical clinical practice. I appreciate Dr. Nirmal, and I am honored to share the dais with him. Next, I should acknowledge here, I would have attended more ophthalmology conferences rather than my own specialty, pediatric surgery. Because there is another secret, sir. And by that way, I have known more ophthalmologists, the leaders in the AIOS as well as in the TNOA, more than my own specialty. On the completion of every conference, Kavita used to tell about the happenings in this one. The one name usually she repeats is the name of Dr. Chitra Ramamurthy. Such a wonderful lady, as Dr. Nirmal said, is a dynamic and ever cheering, ever smiling. Madam, I hats off to you. And you have to learn from her the knack of, the skill of work-life balance, and also competing with their own family members. They are excelling in the field of ophthalmology. I really bow to you, bow my head to you. And I recognize the presence of Dr. G. Raghavelu, sir, fondly called as GR in our IMA Tambram, for his presence here, and he is always guiding us, not only the ophthalmologist and IMA members, all the doctors, with his flawless philosophical and spiritual guidance. Thank you very much, sir, for your presence. And I also appreciate the non-ophthalmologist and ophthalmologist together for sparing your time to be here to learn more. And also, we have the array of excellent speakers to enlighten you. I thank and wish them good luck. And also, finally, I wish Dr. Kavita, I thank Dr. Kavita for her efforts to make this happen, this event happen. I thank you one and all for the opportunity. Thank you.
Thank you, Dr. Kasi, for the nice words and all the secrets that you have revealed. And I now request our guest of honor, Dr. Chitra Ramamurthy, to say a few words and to chair the session which follows.
I think I should not spend too much time between you and the wonderful array of talks which has been arranged. But first and foremost, as soon as I received this invite to come for this particular meeting, it wasn't the joy of coming to a refractive surgery forum, because I have been doing refractive surgery for 27 years. I shouldn't tell that, because you would realize that I'm actually not so young anymore. But having said that, I was so elated about this, because Kavita called me for this meeting. I cannot explain to you all the kind of bonding and affection which has come between us, and it's probably, I keep admiring her, the energy. When I came to the Tambaram meeting, invited by Dr. Nirmal Frederick and Kavita, I know the communications which I had with her, it sort of gradually kept building up, and the meeting was such an amazing meeting, so beautifully organized, and I could see that Dr. Nirmal Frederick as the ringleader of the thing, and the kind of group, the energetic woman he had with him, and doing so wonderfully well, that I even actually went out, I fell down somewhere, but I quietly came back and sat even with the pain and aches, because I had to attend the whole meeting. It was that kind of a meeting, and I went back thinking that when I become the president of my state, of my ophthalmic society, I have to bring in that amount of energy and joy, but I'm not sure. I did my best, but they are a unique group. I think it's been going on for years together, and I guess we all know that Tambaram Ophthalmic Society heads, no? Don't you think so? They head in all their efforts to keep strong amongst all the other districts. And refractive surgery, of course, has been an ever-evolving field, and I'm sure we're going to hear wonderful talks. And I think all of us should clap to Nirmal Frederick also for being an amazing president of TNOA, and week after week, the different dimensions and the way he presents entire ophthalmology in all its angles and corners, and he irons it out for us. So hats off to you, Dr. Nirmal Frederick, for being brought here. I think you should move on to higher levels. And of course, Dr. Kasi, an amazing president of IMA. When I went to their practice some time back, I was truly amazed at the kind of work he has, and the array of doctors he has, and the subspecialty he covers, and also has the modesty to be eternally proud of his wife, who's doing amazingly well. Thank you very much to all of you. I think we shall go on with the refractive surgery session. Thank you.
Now, I request Captain Dr. Raghavelu sir to present a memento to our President, Dr. Nirmal Frederick. I request Dr. Kasi to present a memento to Dr. Kasi. Dr. Kasinathan, please. I now request Dr. Rachula Daniel to present a memento to Dr. Chitra Ramoti. Our keynote speaker today is Dr. Chitra Ramoti. She'll address a topic that perplexes many of us, the development of ectasia on seemingly normal corneas and normal tomography, which is similar to the mystery of endophthalmitis, and she'll delve into the current understanding of corneal biomechanics and where we stand today. So I request her to present.
come on screen. Valla? Oh, you tell me when I could start. Okay, okay. So, a very good evening to one and all of you, and let's go on to the scientific part of this very nice program. And my due in the next few minutes is going to be talking to you about corneal biomechanics, what we understand today, and what is the presumed role with what we understand. Basically, we all know one thing, that the tensile strength of the cornea has a regional variability. That is, the sclera is the strongest, followed by the Bowman's, then the peripheral, I could do with some light here, not able to see the slides clearly. Then comes the peripheral anterior third, then comes the central anterior third, then comes the posterior peripheral third of the cornea, then the central posterior third, and last is the descendant. So that's how the tensile strength of the cornea is distributed. And this was further corroborated in this study with the electron microscopy, which tells us that the anterior stromal lamellae are definitely stronger than the posterior stromal lamellae, and further substantiated by the brilliant microscopic study, which tells us that the epithelium followed by the anterior stroma, in that sequence, this is the distribution of the tensile strength. So we understand one thing, that there is a regional variability in the layers of the cornea, and we know that stroma actually constitutes to 90% of the thickness of the cornea. So that's the amount of contribution it has. And the anterior stroma, with its highly interwoven lamellae, is the strongest, and 50% stiffer than the mid and the posterior stroma. And again, it is resistant to swelling, and it contributes to the preservation of the curvature of the cornea. Then what is the role of the posterior stroma? The posterior stroma are actually fibers which run loosely from limbus to limbus, loosely packed. But again, they have a role. They resist deformation by the ocular recti muscles, which is continuously happening, and the lid blinking. And besides this are the peripheral circumferential fibers, which also absorb the changes in the intraocular pressure. So besides this, there's something called collagen crimp. I'm going to tell you different things. It is basically the ability of a structure to resist deformation. And there is this elastin fibers which are there in cornea, which contribute to the biomechanical variability within the cornea itself. In fact, it's a very non-linear viscoelastic behavior of the cornea as seen. The other important contribution is the hydration of the cornea, which has a role to play in biomechanics, and of course the age-related stiffness and the natural cross-linking which occurs with age. So there are so many factors which are involved. So for a same refractive error like -3, -4 and all, if you look at the slide, you realize that the SMILE procedure consumes more tissue than the LASIK. But having said that, because the SMILE lenticule is taken from the deeper stroma, where it does not disturb the tight anterior corneal fibers, you actually realize that after doing SMILE, you still leave the cornea stronger. Now, these are assumptions. So why do you believe that SMILE may be biomechanically stronger? One, you're not creating flaps, so there is no a cut onto the corneal lamellae. And there is no disruption of the Bowman's membrane or the anterior stroma. I had told you that the Bowman's and the anterior stroma are the strongest, so there's no disruption. The other thing, if you look at SMILE, it does not extend right up to the periphery. So the peripheral cornea is left untouched, as against a femtolasic flap, which extends more to the periphery. So if you look carefully at the slide, in PRK, the biomechanical strength is below the area of ablation. In LASIK, again, below the flap and the area of ablation. Whereas in SMILE, it is below the lenticule, which is removed, but also we know that the cap contributes to the biomechanical strength. In fact, we also now understand that if you make deeper flaps, then there is more loss of biomechanical strength. For that matter, if you were only to do the side cut of the femtothoracic flap, that itself brings down the biomechanics. And even that small delamination cut which you do in SMILE does contribute to the loss of biomechanics. Again, for the same amount of ablation of 100 micron, this was another study done by Dan Reinstein, who felt that SMILE was better than PRK, and then came LASIK. But does it mean that we could do higher corrections in SMILE? Because all of these seem to suggest that. But then we realize that our understanding of biomechanics is only this much. We do not know what is that exact amount of lenticule which can be removed, what is that kind of side cut sizing or the angulation of cut which will not impact the biomechanics, because our understanding or measure of biomechanics is still not strong. SMILE Extra had gained its popularity in different segments, wherein cross-linking was done at a lower fluence energy and did not have a refractive impact on the cornea. These are some 4 popular studies with SMILE Extra procedures which show that they are comparable to SMILE, but then we do not have the best of equipments to measure how much more it contributes. Then there were many of these proponents who had done SMILE Extra in their studies. They have used energy levels at different high levels. Some of them had a temporary haze. So there's no exact measure at which all of us could say that this is how much fluence energy which you would use. Each of us do our own and are happy with that. So there is another complexity here. In the pathophysiology of ectasia, what you realize is a patient may have everything going standard and everything appears normal, but he may develop ectasia, and there may be a person who has some risk factors and he undergoes LASIK and doesn't have ectasia. So probably we need to evaluate the rigidity of the cornea even better. The other thing important is that if we could assess that subclinical stage of keratoconus, that is where the corneal biomechanical decompensation is occurring, probably we might be able to avert more cases of keratosis. Now, this is a slide which shows a healthy cornea, the eye wherein there is a change in the elastic modulus, then comes a biomechanical keratoconus, then the tomographic keratoconus, topography, and the manifest keratoconus. But what you understand from all these different slides is that if you are able to guess that kind of weakness in that cornea, even at the biomechanical state itself, we would have saved many eyes from undergoing laser vision correction. So what is the in vivo techniques which we have? We have the Aura, we have the Scorvis, we have Brillion, we have the OCT-based devices, and the infinite element analysis. The ocular response analyzer has not actually come up to the mark. The Corvis is like an air puff tonometer which measures the corneal deformation amplitude on 16 dynamic parameters, and it seems to appear more hopeful by generating the corneal biomechanical index. It actually tells you based on the amount of amplitude of the cornea and the deflection amplitude and the bent radius. These are some measures which helps. The newer Corvis has many more factors which are being analyzed, wherein it looks at the relative corneal thickness, how it increases from the apex to the periphery, and looks into also that thinner corneas have less stiffness, the densitometry values are measured. So there are a whole lot of measures. Even there are certain enzymes like lysyl oxidase, if that reduced expression of which is known to be causative to ectasia. But one thing we have come to understand, that with the tomographic information and with the Corvis biomechanical data, today the Corvis gives us the TBI index, which seems to be a lot more promising. Now, this is a standard Corvis chart wherein it tells you which eyes are normal, which eyes are suspect, and which eyes are likely to develop ectasia. And it was seen that this TBI, the tomographic biomechanical index, is specific more than 98% compared to the BAD or the CBI. So then, ectasia has 2 hypotheses. One, there is a genetic disposition, but also eye rubbing and atopy and other factors have been considered, and TBI probably would be able to pick up those eyes which are susceptible to ectasia. Now, this is a normal topography, a normal BAD display, and if you look at this tomography, you understand that the TBI, the last column bar, is actually in the red. So, but then The other eye had keratoconus. So that means TBI is showing you something. But then this is another case wherein the topography is normal, the bad display is normal, and the TBI is also in green, so it's normal. So does that mean that is normal, but the other eye had keratoconus? So this is where we are flummoxed, because we keep thinking we have got the right equipment there, but we are still not there. Now this is a patient, everything looks normal on topography, everything is fine, all the parameters are normal. Here the TBI is sort of suspicious, and this is the V1 version of the Corvus, and you are a little concerned, but you go ahead and do the LASIK for this particular patient. Now the same eye on the TBI, the V2 version of Corvus, tells us that the TBI is in the red. So probably, had we checked on the TBI version 2, we would have known that this guy is likely to have developed keratoconus, likely to develop ectasia, and we would have not landed in an ectasia post-surgery. So basically, there are a whole lot of conclusions which come through. The Brilliant microscopy, it looks at the light scatter, and through that it analyzes. But that again, the accuracy of its findings have not been strong. There is this OCT device which looks at the densitometer values, which still are not just there. There are innumerable studies which say, some of them say SMILE is better than PRK than LASIK, some say PRK is better than SMILE and LASIK, but largely by 6 weeks, all of them seem to give normal values. There are a few handful of eyes which have had ectasia after doing a SMILE procedure. So what you conclude from these studies is that corneal biomechanics, as we understand today, is inconclusive in its evidence to say that SMILE is superior biomechanically than femtolasic, because we do not have the right measurement modalities to show the difference. Yes, mathematical models and finite element analysis are telling us time and again that SMILE is way ahead, but then probably till we have the right measurement modalities, we have to continue to be very stringent in our selection of SMILE cases to take them up for procedure. Thank you. So basically, I would say we are a step forward. We are a step closer to an earlier diagnosis, but a lot more needs to be done. Thank you very much. I know I started with my talk wanting to tell you a lot more of corneal biomechanics, but I leave you with the thought that we are still somewhere in the process of understanding corneal biomechanics, but we are not exactly there. Thank you very much.
Thank you, ma'am. Thank you for the very nice talk. I now request you to chair the session. It's my pleasure to introduce our next speaker, Dr. Bhaskar Srinivas. Dr. Srinivas is a former cornea consultant at Shankara Nethralaya and now serves as the director of Code associated with Rajan Eye Care. He is here to kickstart our CMS's insights on the crucial skill of reading corneal tomography. Making the right decision about whom to treat or not to treat is a key to avoiding post-surgery ectasias. Please join me in welcoming Dr. Bhaskar Srinivas.
A very good evening to one and all, and I would like to thank Dr. Kavita and Tambaram Ophthalmic Association for this opportunity. Greetings from Code Eye Care. So basically, quite a few of my talk is already been covered by Dr. Chitra, but it's important to just reiterate the same things so that we remember it better. No financial disclosures, though some of the pictures are from my time at my previous stint at SN. So when you're looking at equipment that helps us understand cornea, we've started off from Placido's disc. We have grown we started off with keratometer to Placido's disc to Scheimpflug images, and now the latest kid on the block is probably OCT-based topographers as such. Each has its own advantages, each has its own disadvantages and limitations, and we need to understand the pros and cons of each equipment before we take a call on what the machine tells us and how much do we take it at face value as such. What are the indications where we'll use these? Primarily is as a pre and a post-refractive surgery evaluation and for diagnosis and management of corneal ectasia. So when you're looking at Placido's device, the first thing that we normally tend to look at is the colors. So we tend to see, okay, red is hot, blue is cold. But then you need to look at the value here, because if it's an absolute scale, it's fine, but if somebody's given you a printout in a normalized scale, it might appear a lot more steeper than what it actually is. So always make it a point to look at what the colors indicate as far as the map is concerned before you come to any diagnosis. The next thing that you would be looking at is the pattern. So you do have round, you have ovals. These are the normal patterns, or a bow tie, astigmatism. Slight irregular bow tie is also fine. But if you have something called as a skewed radial axis, where if you put a draw line here and draw a line here, and this degree is more than 20, you know you are dealing with probably a case of early keratoconus, and you need to be seen. So anywhere where there is irregularity, you need to be careful if you are contemplating a refractive procedure as such. But Placidose has its own limitations because it doesn't give us the value of the posterior curvature, it doesn't give us the value of the thickness, and sometimes there is a concept of a displaced apex, so it might appear steeper inferiorly, giving rise to an indices which might pick it up as keratoconus suspect. And this is where the genesis of the Scheimpflug based imaging came in. In the Scheimpflug based devices, you generally have pentacam, which is commonly mentioned and commonly reported. The other devices are basically the Cirrus and the Galilei. You do have a lot of users of Cirrus. Galilei, however, the users are a little bit limited when you compare it with the other two devices. So here you basically get a 4-quad map, and you need to look at what the maps tell you. It tells you your sagittal curvature or your tangential curvature based on what you have put. So here the first part would be to look at it like how you would look at a Placidose device to see whether the topography shape is normal. Then you have the anterior and the posterior elevation values and the pachymetric values. So when you're looking at any abnormality, if the abnormality in one area is coinciding with the abnormality in the other maps, you are going to be a little bit suspicious about it. So before you read the maps, you need to know what it involves. It involves the anterior cornea here, it involves the posterior cornea details here, then the thickness, and then the anterior chamber details. So when you're looking at this patient who presented for LASIK, the other eye was absolutely normal like the previous patient that madam had shown. But when you look at the tomographic maps, yes, it shows an irregular asymmetric bow tie, it shows inferior steepening, it shows elevation values which are high. So this actually is a keratoconus suspect. Keratoconus can be significantly different between one eye and the other eye. So before you label any patient with a fit candidate for refractive procedure, even if he has error only in one eye, you will always get the topography done of both the eyes before you come to a diagnosis that yes, this is normal and you want to proceed with treatment. Again, you have something called as a bad D, where they remove the central 4 mm around the steepest area and then they draw the best fit sphere, so that the idea is the elevated points will kind of show up a lot more easily for us, and anything in red, we tend to get drawn to it and we look at the maps more closely. Yes, it does help us to identify some of the subtle cases as such, but it is not an all or none law. You still have a lot of patients where you will have a gray zone. Yes, when it goes into the red, you are concerned, but when it is in that yellow, you are still not sure whether it would be an ideal candidate for a laser refractive procedure, and that is where you have the role of biomechanics or you have the role of epithelial mapping to try to add on to what more information you can get from the investigating tools before you decide on the safety of refractive procedure. So if you're looking at a Scheimpflug device, when you're looking at the sagittal maps, you're looking at basically patterns which tell you that there is a skewing, there is asymmetry, and there is a change in the shape which is not normal. And when you're looking at elevation values, as far as pentacam is concerned, you have certain values. You say you have a 16 mm on the posterior elevation, which is the BFS of 8, because you can't change the diameter of your BFS. If you change the diameter, then that reference value will change. So you need to be sure that you set your machine into that particular pattern. And you don't have to remember all this, because luckily most of these get color coded into the maps themselves. So they will show it up as yellow or red in the map. So we really don't have to remember these values unless we are a postgraduate and we have to write it in our exams. When you're looking, but what it basically tells you is you want to look at both the eye, you want to look at all parameters in both the eye, and if there is a significant deviation, whether it is the thinnest pachymetry in one eye versus the other eye, whether it's a deviation of the superior form versus the inferior. So you would expect all parameters in an eye to be reasonably similar. You would expect that eye to be similar to the other eye, and that is what we call as enantiomorphism. So if there is a deviation, it tells you that you need to look at it more closely. You also have something called as the ABCD display, which kind of tells you with respect to keratoconus how the condition is worsening or progressing, and nowadays most of the machines also kind of give a Bellin ABCD value when they give you the topographic reports. Biomechanics has been added on with pentacam. Unfortunately, the Corvises has a tie-up only with pentacam. It doesn't have a tie-up with the other machines, so you are limited. and it tends to give you some more information because it adds on the tomographic data to the biomechanics and gives you a TBI and a CBI value. CBI was the initial value, which we feel is not as reliable. So when you're combining TBI with the TBI, which combines both the tomography and the biomechanics, you tend to have a higher possibility of identifying a subtle keratoconus as such. But again, like Madam said, it doesn't work in all cases. So our understanding of a formafrust is still limited to a certain extent. We cannot be 100% sure that we have identified all formafrust keratoconus and said that it's an absolutely normal, because how genetics play a role, how hormonal changes play a role, how patients' habits play a role is something which is yet to be, the effect of it on keratoconus is yet to be proven. So Cirrus is the other contemporary in terms of Scheimpflug-based devices. Basically gives you the same thing, but it's a lot more simpler. It bases it on an artificial intelligence platform to kind of give you, so it tells you normal, abnormal, which even Pentacam tells us. Cirrus, we don't have specific values that we look at, but even though if you want to actually go deeper into the machine, you do have values. And again, the good part is it is shown up in green, yellow, and red things. So you can see this value is in the red, so you know this is abnormal. This value is in the green, it is normal. So when you're looking at a map, at least we don't have to remember the numbers. We just need to look at the map to look at what is the deviation in that eye from the surrounding area and what are the values which are in red for us to know that this is a reasonably abnormal cornea and we don't want to be doing a refractive procedure. This is the other eye of the same patient showing an advanced keratoconus. So the latest kid in the block is the use of OCT-based devices, which again gives you the same. It has a placidus disc to capture your anterior curvature, and the OCT device is used to give you your anterior and posterior elevation values. Since this is from the same company in terms of the Cirrus and the MS39, the map kind of looks similar. The additional benefit that the OCT gives you is because of the resolution, it is able to tell you how thick the epithelium is or how much thickness is the residual stroma. And it is important to know that because sometimes the epithelium on top of the cone, we do expect it to be thinner, but in certain situations, it can actually be thicker. And when we are doing a cross-linkage in those patients, you need to actually measure the stromal thickness before you do a cross-linkage as such. So any patient where you're planning to do a cross-linkage with a borderline pachymetric value, it makes sense to actually look at the epithelial thickness across the area, that the central 8 mm area or the area of the cone before you take a decision on whether you are going to be doing the cross-linkage at all or you just plan for a contact lens for now and a corneal transplant subsequently. So this tells you the stromal thickness, it tells you the corneal thickness with a normal value as such. And again, it kind of gives you, so the maps look similar to the Cirrus and the thing because the software is kind of built on a similar platform, but it adds on the epithelial thickness and the separate stromal thickness value to the map as compared to just the Cirrus, which gives you only the 4 quads. So this gives you the indices. Again, like you can see how much is the epithelial thickness, what is the minimum thickness, what is the average, everything kind of comes up. It also allows you to look at comparing values at one point to the other. So if a patient has come to you and you've deferred the procedure for whatever reason and you're just following up the patient, it will help you to see whether there is a worsening of his keratometric values, whether there's a worsening of his elevation values or pachy values over a period of time, which can give you a subtle idea that this is a weak cornea and you don't want to be doing a refractive procedure. This is what you classically see in a keratoconus or an early keratoconus patient would be a thinning of the epithelium on top of the cone and a thickening of the epithelium around it, giving rise to a donut pattern. But it might be very subtle in the initial cones. So where would you want to use epithelial mapping specifically would be if you get a red spot in the anterior surface in a bad, I would want to look at it. If I see a steepening which is not coinciding with other parameters, in my sagittal map alone is steep, all my elevation parameters are normal, I would look at the epithelial map to see whether the epithelium is answering something as to why it is steeper in that area. If the epithelium is thicker in that area, obviously the steepness comes in. So it gives me an idea what is responsible for the red spot in the anterior elevation maps as compared when your rest of the posterior elevation maps, all the other parameters are normal. So this was what I was saying. In this keratoconus patient, you can actually see the epithelium is thicker, and this is the thinnest part of the cone. And if you can look at it, the thickness is only 280. So overall thickness 347. Yes, I would have put HPMC. Maybe I would have thought it would have increased to 400, and I would have done a hypotonic CXL. But with a 270 or a 280 stromal thickness, I would have ended up with endothelial toxicity in this patient. So it's important if you're doing any cross-linkage for a thinner cornea to be sure that you know what your epithelial thickness is, because that's debrided before the procedure. Ideally, the Dresden protocol was for 400 without the epithelium. We have kind of taken it in our side, because we ended up seeing patients which were more advanced. So we have utilized, we have debrided the epithelium and we have done the procedure. So we need to be careful when we do a hypotonic CXL. Again, post-refractive surgery cases, pre and post, you have a lot of information. If you want to see the effect of a refractive surgery, a tangential map kind of helps us to understand what is happening. Just a couple of cases. So this patient with a high refractive error, fairly good pachymetric value and a good Schirmer's. Maps, broadly speaking, looks normal, but you see there is a slight asymmetric bow tie. There is an increased elevation in the back elevation is there. Thinnest pachy is dragged down by close to around 0.76 mm, which is probably a little bit of a subtle sign that you're seeing. The bad D values are borderline. The tomographic values are picking up an inferior height decentration again because of the decentered thinning, and it is probably putting it as a TK. So here at least you're seeing a red and a yellow flag, so you know. But if it had been a little bit more subtle, it would have been difficult for us to diagnose. Again, look at the other eye. The other eye also has a similar pattern. So elevation values are borderline, slight asymmetric bow tie. But here the bad D values are actually normal. So if I had just seen this eye, I had not seen the other eye, I might have said fine, everything else looks absolutely fine, and would have gone ahead with the refractive procedure. Again, look at the other maps, because sometimes when they give us the map, if the machine is not in your place, they might just give the 4-quad map and the bad D. You might not look at the other maps because you don't have access to it. So you might want to look at these values again to see that it has come in a red, so you would want to be a little bit careful. So both eyes are showing subtle signs where you need to be careful. Corvus was absolutely normal, so biomechanically it is stable. Would you want to do it? In this patient, because it was a higher refractive error and there were 2 signs which were borderline, I decided to go ahead with an ICL rather than go ahead with a refractive procedure. If the patient had a lower error, say maybe about a 2, 2.5, then maybe I would have discussed with the patient. I would have probably asked the patient to come back 6 months later, reassess, and if the patient is very keen, probably offered a PRK or an epilastic. Again, between PRK, SMILE, we still are not sure which is the most stable biomechanically as such. So we would probably err towards a less invasive procedure as compared to a SMILE. But you have different thought process because you are ablating the anterior cornea, which is a little bit more stronger. SMILE removes tissue from the deeper portion. So you have proponents for both saying that SMILE is as safe as PRK. But generally, if you look at literature, the number of cases of PRK developing ectasia is almost negligible, whereas you do have SMILE ectasia cases. That's probably because we became over enthusiastic in treating it. But at least in literature, you don't get too many PRK ectasias as such. So there's another patient where he's come for refractive correction. He's had a LASIK done earlier. Now he's complaining of glare. The LASIK was done in 2007. Mild refractive error. He also had a bit of cataract. Cataract was more in the left eye as compared to the right eye, and he was complaining of significant glare. So if you look at the topography, it's an absolutely decentered topography in the right eye. Cataract was more in the left eye. The left eye topography was slightly better. So then the decision was, how do you go about doing something for this patient? You look at the eye tracing. The eye tracing shows you there is a significant component of astigmatism, both because of the corneal irregularity that is there. And if you look at the DLI, it shows it's around 6.4 for the right eye. So the cataract was not as much in the right eye. But whereas the left eye, where the topography was regular, he had issues more because of the lens. The DLI was lesser. So for the left eye, we gave the option of just doing a cataract surgery alone. For the right eye, we first went ahead, did a topography guided treatment to regularize the corneal surface, and then went ahead and did a cataract surgery. So to conclude, there have been improvements in imaging devices, but subclinical or formiferous keratoconus is still a challenge. We will not be able to say for certainty that yes, we would be able to identify each and every formiferous keratoconus as such. There is no one single criteria which can tell us that yes, this is abnormal. We don't have it, neither TBI, biomechanics, brilliant, nothing gives us that one value that we can say is sacrosanct with keratoconus. You need to evaluate every patient, look at the anterior curvature, look at the posterior curvature, look at the elevation values, thickness, epithelial mapping, biomechanics if you have access to it. So you have to look at it as a composite and then take a decision, especially in borderline cases. Luckily for us, most of the tools are able to pick up these subtle changes in about 90% patients. So it's only in the 10% patients that we really have to break our heads so much. Thank you.
Thank you very much for a very nice talk, Dr. Bhaskar. Just one message to all the all the attendees here. Up to what error would you do a PRK? And when would you decide not to do a refractive procedure? From which bar onwards?
So generally, I've been doing PRK till around 6.5. Before, above that, I would probably prefer either a smile or a LASIK. If the patient has a thin cornea and we don't want to do a smile or LASIK, then I'll probably go for an ICL. Generally, above 10, I don't prefer a laser-based refractive procedure. I prefer an ICL-based procedure because quality of vision I feel is much better for that, and the predictability of the outcomes are much better with an ICL or an IPCL kind of a outcome when you were dealing with a higher error.
Yeah. We've become even more careful beyond -8. We move on to phakic IOLs, actually. Thank you very much.
Sure, thanks.
We shall now go on to our next speaker, Dr. Kasinathan, who is going to be talking on peripheral retinal degeneration refractive surgery. I think that becomes very, very important that we don't just keep looking at the topography and the corpus and take a decision. I think we need to examine the retina because these are myopes. They could be having weak areas in the retina. They could be glaucoma patients too. So we need to be sure, and he's going to highlight that. On to you.
Thank you, ma'am. I would like to thank audio. So thank KK Hospital team and Dr. Kavita for having me here. I'm an odd man out. So all over people are asking me, what are you doing here? You're a pathology. So never a pathology because as I keep telling, I will come to the slides later. So examining the retina is very important. When you are in an institute, my close encounter with cornea was, I think Bhaskar would remember, close encounter with cornea is when I was doing a VR surgery in a high myope. So I know I do good artworks in retina, laser, endo laser, we used to paint the fellow's name, our name and all sometimes. But when I'm doing a cornea vitrectomy in a high myope, you know, just like that we scrape the epithelium for visualization. So when I was scraping the epithelium, it came like a button. I thought, oh, I'm so good at scraping the epithelium just like a button. Then I got doubt and called Bhaskar, who was operating next to me. He said, you've taken the flap. So I told them, let the flap be there itself. I'll finish the VR surgery, then Bhaskar will come and suture the flap. So that's a close encounter with the cornea when I did when I was in Shankar Netralaya. Is it? Okay. Type C. Pen drive venumappa. Idhila read alaya. Illa idu type C illa. Inda idu. Pen drive kodu. Pen drive kodu. Illa adu vandu in the slides move. Next person, let them speak. I'll copy in the pen drive so that let us not waste time.
We'll go on to our next speaker, Dr. Soundaram, who's going to be talking on microkeratoma LASIK, its role in 2024. I think that's a very important thing. We all have to need to understand Clarity Eye Care Hospital in Chennai.
Dr. Soundaram is a cornea consultant at Clarity Eye Care, and she's a dynamic secretary of Tambaram Ophthalmic Society. She is known for her sound presentation and sound knowledge. Dr. Soundaram will discuss.
Yeah. Happy evening, one and all. At the outset, I would like to thank KK Surgicals and Dr. Kavita Lakshmi for having me here. And moving on to my topic, microkeratome LASIK, its role in 2024. So the alternative title would be, should I still need to use my microkeratomes in this small lenticule and femtobladeless era? The scope of my talk would include the advantages of microkeratomes, the LASIK procedure, the principle behind it, the components used, the console, the suction ring, the microkeratome head, the flap creation, few clinical studies, and why microkeratome LASIK should be need to continued. So advantages of mechanical microkeratomes is that it does have a proven history of around 25 years where innumerable number of surgeons have done a lot of cases. It does have a lower cost and it's relatively inexpensive and a more efficient surgical flow from the suction on time to the suction off time is only less than 30 seconds. And it has an easy learning curve for surgeons. For new learners, they can master the procedure in a very few number of cases, less inflammation compared to any other surface ablation procedures, and almost always consistent results after the refractive procedure where the patient is free of glasses and he has his expectation completed. And affordability in a country like India, affordability does play a role, and hence this remains a gold standard champion for out of all the refractive surgeries. So this is the procedure. We mark the cornea, then we, after keeping the suction ring and raising the intraocular pressure to around 65 millimeters, then the microkeratome head vacuum is, after the vacuum, the blade is passed, then the flap is raised. After the flap, the laser ablation is done, then after cleaning, the flap is repositioned and the surgery is completed. So the principle behind is to dock using a suction ring. The high precision oscillating blade systems creates a lamellar corneal flap while the cornea is held under a high pressure. The components of the microkeratome system include the console, the motor, the microkeratome head, the applanator lenses, the vacuum fixation, the flat stock ring, and the foot switches. The console contains the electrical equipment that has the switches, and the vacuum shows a preset and the actual rise is displayed. The maintenance of rising and accurate and maintaining it through the vacuum throughout the procedure does play an important role in the whole procedure. When the intraocular pressure becomes low, the oscillating blade needs to be stopped or the cut needs to be aborted. The principle behind the microkeratome is that it works on the principle of the carpenter's plane. So the blade is usually fixed at a distance from the applanation plate, which determines the thickness of the slice. The suction ring and the vacuum pump applanates the cornea, initiates the procedure. The vacuum is raised up to 65 millimeters of intraocular pressure, which is checked using a Barrequest tonometer. If the pressure is low, not enough, then we end up having thin or irregular flaps. If the pressure is very high, then we end up having chemosis, hemorrhage, or an optic nerve injury. The selection of suction ring becomes important because it determines how much cornea protrudes through the suction ring. If it's a steep cornea, more tissue protrudes, and if it's a flat cornea, less tissue protrudes. There are nomograms which can be based to select the suction rings. The motor initiates the movement of the microkeratome head, where we have different generations of the microkeratomes. Initially, we had the linear cutting systems, then the translation and the rotational systems. Now, the oscillatory pendular SBK microkeratomes are available. The translational microkeratomes usually create nasal hinges, and the pivoting systems create superior hinges. The latest is the disposable use suction rings as well as single use, one use SBK Moria microkeratomes are available, which are disposable ones. The linear flaps created by translational microkeratomes have the advantages of having an intra-op visibility during the flap creation, and the flap is more of a planar profile. And the disadvantage is that it has a fixed hinge positions. The Amadeus and the SBK microkeratomes use this modality of principle. The rotating or pivoting flap creations has the advantage of a less space, and the hinge placement can be variable. Either the nasal or the superior is possible, but the flap is thick, thin, and thick. It is a minuscule flap due to the upward movement of the suction ring, and the Hansetome usually creates this kind of a flap. The microkeratome blades are usually stainless steel, and before assembling, it can be viewed under the microscope so that they are devoid of any pittings or residues. The blade oscillation is then started, which is the horizontal movement alongside the fixed guarded track. There are different sizings of the blades available so that it can be varied. The flap thickness depends on the position of the blade from the applanation plate, and accordingly the thickness can be varied. the oscillation speed is usually around 15,000 rotations per minute with a blade angle of 24 to 30 degree, which is the faster the oscillation, we get a smoother cut. A few studies which have demonstrated that the 1 plus SBK microkeratome have given flaps of 100 microns, which have accuracy and predictability equivalent to the femtosecond laser flaps. And there's another study which have observed that the uncorrected visual acuity at day 1 post-op as well as the 1 month post-op were still better than that of a femtosecond flaps. There are studies which have demonstrated that the anterior segment OCT, the SBK microkeratome flap can produce a planar flap, which also has the advantage of better healing. There are other studies which have a comparison between the different microkeratomes heads between the Amadeus, Carrizo, Moriam M2, SBK, Nidec and the Hansatomes, and they have given conclusions that there do exist a variability between all 6 models. The thinner corneas had thinner flaps, and similarly the thicker corneas give us a thicker flaps, and always when we use the same blade for either eye of the same patient, the first cut eye has a thicker flap than the second eye. The advantages of LASIK over PRK is that the patient has no or minimal pain, and he has an early visual recovery, and there is no residual haze, and also high myopia correction is possible. And when we combine LASIK with the topography guided laser technology, it has a very advanced benefit of having a personalized surgery, and the patient does have a very superior quality of vision, having better treatment of astigmatism and decreased glare, sensitivity to light and difficulty at night driving. So when Contura Vision LASIK was compared with SMILE, against all the comparative parameters used, the Contura Vision LASIK was much superior in contrast sensitivity, a spherical equivalent refraction, the residual cylinder refraction, and also the objective scatter index parameters. So why should I choose a microkeratome LASIK? Yeah, it does meet all the primary goals of what a refractive surgery is needed for us. It has the safety, the reproducibility, the accuracy, stability, and the cost. So in whatever form of evolution the refractive surgery takes, and it does have a special role. And old friends are gold, new friends are diamonds. If you get diamonds, don't forget the gold, because only gold can hold a diamond. Thank you.
That was a nice talk, Soundaram. You did your best to debate for microkeratome LASIK, but I do believe that microkeratome LASIK has its limitations now, because we have really evolved in PRK. And I was going to go on to Kavita Lakshmi. So we first have Dr. Kasinathan talking on peripheral retinal degenerations and their role in refractive surgery.
Good. So people ask me whether I'm an anterior or posterior. I'm an anterior segment surgeon who can manage my own complications. That's how I put it across. And now Dr. Kavita is pushing me to do refractive surgery also. Right. And you know, the most valuable gift by a fellow, it still adores my practice, is a portrait like this. Dr. Bragadish, most of you know Dr. Bragadish. So he's a very knowledgeable person and a very lateral thinking person. So when there was a debate asking whether a VR surgeon can do cataract or not, this is the picture he put it in the debate against me. So now I have to add Rashmika also for refractive surgeries in this picture, I guess. So, So refractive surgery, people have to understand, refractive surgery is only to reduce the risk of refractive errors and not the refractive pathology. So people will ask, whenever doing a high myopes, when you're doing a refractive surgery, does it eliminate the risk of the retinal pathologies? No, because you're treating only the refractive error and not the retinal pathologies. It's not moving. Okay. So the posterior segment complication, whatever the literature says, what are the posterior segment complications which has been documented after refractive surgeries? Anything in the retina, any problem which in the retina has been documented after a refractive surgery. The PVD, the vitreous trauma, rhegmatogen retinal detachment, giant retinal tears, retinal breaks. When you go through the literature, all these things have been reported after a refractive surgery. But you have to also understand you are doing a refractive surgery in a high myope, which already they are predisposed to all these risk factors. And then the incidence of retinal detachment after refractive surgery, it somewhere lies between 0.02 to 0.2%, which is very much compared to a normal eyes for the risk of retinal detachment at an old age. And these are the various literatures available, but most of the literatures, most of these is meta-analysis, and at the end of it, the literature said that the refractive surgery didn't specifically increase the risk of retinal detachment. So that's a good thing. And what are the questions which we need to answer? Is there an association between the VR complication and LASIK? Is it a LASIK related complication, or it's a coincidental one? Is it a cause and effect, or just a coincidental one? Or is the prophylactic laser recommended? I'm sure at the end of my talk you'll be able to answer that. And can we prevent or avoid the VR complications following the refractive surgeries? So whom to be blamed? The patients, because the pathology, the macula, because of the pre-existing myopic pathology, or the laser per se, does it cause the VR complications, or the microkeratome and suction ring, or the intraocular procedures like the phakic IOLs and a clear lens extraction. So the basic risk factors are the refractive error. Higher the refractive error, more thinner the retina, more chances of peripheral retinal degenerations, and more risk of having retinal complications. And again, age of the patient, if the patient is more than 30 or 40 years, the risk of retinal complications is more. The very reason because of the posterior vitreous detachment which sets in at the later age, and the PVD status. This is very important to look into the PVD status and document whenever you do a refractive surgery. And most patients are myopes. You need to understand there is the pre-existing pathology in the eye even before the LASIK. And myopia is a known risk factor for retinal detachment. And there is one single anecdotal report of retinal detachment following a hyperopic LASIK. And the lattice generation, incidence of lattice generation in myopia is around 4.5% in normals, whereas when the higher the myope, more than 8 diopters, the risk of lattice degeneration is around 29%. And in a myope, there is a premature liquefaction of the vitreous, that means a premature posterior vitreous detachment. All these factors predispose for the retinal complications, and it's not the LASIK per se. And there is a peripheral retinal thinning, and more the myope, more the dioptric power, more the incidence of retinal detachment. This is the natural course and natural history, not with the LASIK per se. So what does LASIK do? What biochemical or biomechanical or biochemical changes it does to the retina or the posterior segment is, there are shock waves which has been generated by the laser, and the suction ring, what you use, it causes increase in the intraocular pressure and causes the equatorial lengthening of the globe, also the axial lengthening of the globe, and there are some thermal effect because of the laser. Coming to the laser per se, the fluoride dimers, they don't have much penetration. As in the previous talk they were talking about, the penetration is maximum. Increase in size of the corneal, whatever the button or whatever you call the flap, more the size of the flap, more the penetration. So the average flap size is, if I'm not wrong, it's between 1.5 to 6.5 millimeter, and with an average of 3 to 4 millimeter, the penetration is only 4 millimeter behind the endothelium, whereas if it's 6 or 6.5, the penetration is around 6 millimeter posterior to the endothelium, which will somewhere lie in the anterior hyaloid phase or retrolenticular space. That much is the amount of the shock waves which can travel in a vitreous cavity post-LASIK. So this is what I mentioned, bigger the flap size, more the penetration, and more the ablation, and more the power in ablation, more the penetration of the shock waves. And then the suction ring, coming to the suction ring, and the suction ring which causes the equatorial expansion of the globe, and there is an increase in intraocular pressure around approximately, or average, I think around 65 millimeters of mercury, but it can go up to 100 millimeters of mercury. And there is a sudden increase and rapid decrease. It happens in seconds, so that's why it doesn't cause us much of a problem. But there is a sudden increase and decrease in the intraocular pressure can cause a mechanical stretch on the vitreous base or the peripheral retina and predispose to retinal detachment. As I said, very high IOP, average of 65 millimeters of mercury, can cause lacquer cracks in a pre-existing myopia where there is already retina is thinned out. And high reperfusion pressure after the suction ring causes foveal hemorrhages and also compression by the cutting heads. This is one experimental porcine eye where they have seen that mean axial length from the baseline, that is 24.2 millimeter. With the suction ring, it has become 24.6 millimeter. And along with the cutting, the flap creation, the axial length has temporarily increased up to 31.5 millimeter. This is a porcine eye, which was histopathology, they demonstrated this. So that such much is increase in the equatorial diameter and the anteroposterior diameter in a human eye, and it's very difficult to see in a human eye. But This is what you need to understand. There is a lengthening of the globe. Coming to the posterior vitreous detachment, yes, this can happen because of the mechanical stretches induced by the various forces which I told you before. And there is incidence of the new PVD which has been documented is between 9.5 to 21% in post-LASIK. And of course, the refractive error is more, the incidence of PVD is also more. And when you do a prophylactic laser barrage, is it something different when you do a normal prophylactic barrage? No, it's all the same. And do you need to do 360-degree barrage? No, it's never indicated. And LASIK should not be a deciding factor for a prophylactic barrage. That's what we say. That's what when I went through the literature, in fact, after reading through the literature, I myself my thing was also open that I was thinking that any lattice has to be barraged. No, because they found the retinal detachments in non-lasered areas and adjacent to the previous lasered areas. Even in Shankar Netralia, one of the study of for 10 years follow-up, they found 5 retinal detachments, out of which 4 had previous laser marks, previous prophylactic laser, then they had a retinal detachment post-LASIK, and one patient didn't have a laser but still had a retinal detachment. So LASIK should not be a deciding factor for a prophylactic barrage. Of course, there are some risk factors which I'll come to later. And this is one patient, a pictorial representation. This patient had multiple lattices and 360-degree barrage. We don't do 360-degree barrage, but this patient had a 360-degree barrage. But post-LASIK, he developed a HST posterior to the laser mark. And this is a documented case. And the reason for this, because laser will form a firm adhesion of the vitreous to the retina. Laser is just a pixie. So it forms a firm adhesion with this amount of forces inside the eye. What happened? The vitreous is being pulled. And the strong adhesion is the laser sites. So in the strong adhesion sites, there is a pull of the vitreous and causing a tear. So that's why we say unnecessarily don't need to do a prophylactic laser in lattices. So what are the barrage recommendations? Is the at-risk patients. Who are the at-risk patients? Symptomatic PVD with any lesions. If the patient is complaining of floaters and flashes, you know that it's a symptomatic posterior vitreous detachment. These patients, any lesions, according to me, can be lasered. But of course, with a laser which is not too intensive, it has to be a prophylactic barrage, not a therapeutic barrage, what we call. And if there is a horseshoe tear tells us there is a dynamic traction. Horseshoe tear is nothing but a dynamic vitreous traction. When there is a dynamic traction, yes, you need to do a prophylactic barrage. And if there is any family history of retinal detachments, yes, you need to do. And vitreoretinopathies, when you do in a Marfan syndrome or any vitreoretinopathies, when you do a refractive surgery, these vitreous are already pre-existing pathologic vitreous. So you need to do a prophylactic barrage. These are the recommendations. I'm not going into this. These you can see in AO recommendations for the prophylactic barrage. And the time interval, the other common question is what is the time interval between the laser? Because the laser adhesions takes at least 2 to 3 weeks time. So that's the time we recommend. If at all they want to be a prophylactic barrage, you want to do a refractive surgery, the time interval is between 2 to 3 weeks. And this holds good even for cataract surgeries. And during the vitrectomy, that's what I mentioned, be aware of the flap. Just as a VR surgeon, just don't scrape the epithelium, be aware there is a flap over there. And then phakic IOL, because a lot of phakic IOLs are there, they never hinder the visualization. So you can do a good vitrectomy even with a phakic IOL, no need to remove the IOLs. And band scan, because you're doing refractive surgery, you have done a refractive surgery in a patient just to negate the refractive error. So when you put a silicone band, when you put a scleral buckling, the axial length can increase. So the patient has to be well informed. The very purpose of LASIK is not being met. So the prevention, pre-op dilated fundus examined with an indirect ophthalmoscopy, I would recommend all of you just have to master an indirect. All the refractive surgeons should learn doing indirect ophthalmoscopy, and all the VR surgeons should learn refractive surgery. So pre-op fundus examination is mandatory with the indirect ophthalmoscopy to pick up all the peripheral lesion and document the status of vitreous, whether there is a PVD or not. So you know whether it's a pathological PVD or a pre-existing PVD, and document all the lesions, lattice degeneration, tufts, breaks, subclinical RD. And post-op examination, patients after LASIK, if you say hazy vision, just don't brush away because it's a interface haze or striation of the flap. Have to look at the fundus as well. So to conclude, pre-op evaluation and documentation is mandatory, and post-operative periodical retinal evaluation of these patients for at least a year is necessary. And if the patient complains of floaters post-refractive surgery, please do an indirect ophthalmoscopy, and also you can refer to Clarity Eye Care. We'll do the best for them. And barrage the at-risk patients. Whatever patients I mentioned, those patients has to be having prophylactic barrage. And this is the recommendation for follow-up. This is a nice, again I saw, this is from Narayan Netralaya. patient with a refractive, whomever is planned for a refractive surgery, if he has a PVD, the protocols are different because PVD is an evolving process. The normal PVD gets completed by 6 months' time. So according to this paper, they say wait for 3-4 months if there is a pre-existing PVD when you want to do a refractive surgery. I don't think so that's practically possible. And if there is a PVD, then wait for 4 weeks. If there is a lesion, treat it. If there is no risk lesion, follow it up. This is a nice thing from Narayan Netralaya. And post-refractive surgery, if the patient complains of floaters, please do a thorough fundus examination. Thank you.
Thank you for a very detailed talk. There's a lot of information got related to us. And I think we don't have any questions because many of my questions at planned were answered here. It is just that if you were to do a clear lens exchange and the patient has PVD, would that make you more comfortable about going and doing a clear lens exchange for that patient?
How does it matter, madam? PVD status and the clear lens extraction.
No, normally clear lens exchange is something
High myopes.
we would not do at all for high myopes.
Nowadays, I don't think so anyone is doing clear lens extraction.
No, we can do it in those presbyopic age group when a person is hyperope and after evaluating and all that. There's a small segment of people who get clear lens exchange done. So I was under the impression that if the patient already has a PVD, it is safer in doing a clear lens exchange.
Yes,
for these
because the
patients.
dynamic vitreous traction is already broken with the PVD. So if there is a PVD, yes, it's a good thing to do. Even you do any vitrectomy or you do a refractive surgeries on the pre-existing PVD and there is no lesions, yes, safely can. The vitreous is the culprit over here.
Thank you.
Thank you.
So we go on to our next speaker, Dr. Kavita Lakshmi, who is going to tell us why we have all moved towards advanced surface ablation and what are the issues which have got cleared out for us to opt for that. Thank you. Probably she would also tell us that microkeratome LASIK is actually out now.
Good evening, one and all. My talk will be on how advanced is advanced surface ablation. Let me begin my presentation with 3 case scenarios. The first scenario is a 24-year-old lady. She is a moderate myopia, having minus 3.5 diopter on both the eyes. Her topography was normal. She had mild dry eyes. Her corneal thickness was around 480 microns and fundus showed peripheral radius with holes. And there was also a family history of glaucoma. Well, the second scenario is a 30-year-old gentleman. He is also a football player and he has a significant astigmatism. The thinnest pachy was around 560 on the right and 556 on the left. And it was the corneal topography showed higher order aberrations as well, the aberrometry. And the case scenario 3 is a 28-year-old gentleman. His right eye had a myopia of minus 8.5 and the left minus 7.75. And the thinnest pachy was 540 and 536, but the anterior chamber depth was only 2.7. He's a contact lens user. He had a healed corneal scar, a superficial scar. So these are the 3 hypothetical case scenarios. So in all these cases, we find that femto or microkeratome LASIK was not possible or SMILE was not possible. And in the last scenario, even ICL was not possible. And when the patient wanted freedom from glasses, so the only option that was left was photorefractive keratectomy or surface ablation. The surface ablation has undergone a lot of refinements and phenomenal advancements over the years that it has seen a resurgence as advanced surface ablation and is being widespread and widely used even as a primary treatment option. Why can't it be used as a first choice of treatment? It can be because the smart pulse laser, which is being used now, is so many light years, it's so very fast, it's so many light years ahead of the age-old broad beam lasers of the early 1990s, which was the one which was associated with haze, regression, and a lot of disrepute. And now it is available as a single-step laser platform. So there is no 2 modules of PTK and then you have to shift to stromal ablation module. So the reduced treatment time and reduced stromal dehydration and asymmetric ablation, and hence the results are more accurate and more predictable as well. And the Smart Pulse ablation software with its unique spot geometry is so very smooth on the stromal bed post ablation. So it leaves behind a very smooth stromal bed for faster healing as well. And the iTech technology reduces the thermal load, and all these translates to reduce pain, reduce haze, and a quicker recovery time as well. So it is a ray of hope for those corneas which are thin, for myopia, hypermetropia, and for astigmatism because of the excellent cyclotorsion. There is no need to mark 0-180 as in other smile or other procedures, and the amazing eye tracking also has a perfect centration as well, and can be done on highly aberrated corneas, scarred corneas, superficial scars, and those with epithelial basement membrane defect as well. And it can be done as an enhancement procedure and retreatment even without lifting the flap post-smile and post-LASIK, and on borderline candidates where they are unsuitable for ICL, where the anterior-chamber depth is very less and affordability is an issue. So a brief history will certainly fascinate us. So first it was radial keratotomy, and then the excimer laser, which shaped the millions and millions of cornea worldwide, and then the LASIK, the microkeratom, then the femto, then the smile, then the trans PRK, and now it is the smart trans PRK with a single step laser platform. So conventionally, photorefractive keratectomy was done where the epithelial debridement was done either mechanically or using an alcohol debridement or a Moyle's brush. But this laser-assisted epithelial debridement is so very smooth, and the epithelium healing is very quick and very fast. It happens within 3 days, and it is worth watching a video which shows that it is all a single laser, single step procedure. It is totally touch-free. No suction is applied, no flap, there is no cap or no kind of incisions or cuts are made. It leaves behind a biomechanically strong cornea, and the Smart Pulse laser is really very smooth on it. And these are some of the benefits at a glance. So I would like to focus on one thing, that is the unparalleled patient safety and comfort through extremely fast ablation of 1.3 to 1.5 seconds per diopter. So the fast ablation means more patient safety and comfort. Risk of corneal dehydration is minimized. The patient's fixation time is also reduced. And these machines have an excellent eye tracking system as well. And the smart surface technology, as I had already mentioned, leaves behind a smooth stromal bed and faster healing. And this is the trans PRK post-op timeline. The patient can be off the contact lenses in 3 days, and in a week's time they can resume most of their work, and in 2 weeks' time even they can resume water sports. So there are very few studies which actually compare directly trans PRK with LASIK or SMILE, and one such study is a Chang et al. Study, and it really does show that the biomechanical stability is strongest with PRK and intermediate with SMILE and least with LASIK, and the eye tracking system and cyclotorsion compensation is all excellent with this trans PRK, and the customized treatment profile is also possible in this. So I've talked all the good things about trans PRK. What is the worst possible complications? So the worst possible is haze, and that too with the use of mitomycin C. It is less of a concern, and a post-operative regimen of steroids also reduces the kind of haze we see. We hardly see any haze nowadays. But if it happens on patients who had some prone for keloid or exposure to UV rays is more, that resistant tough haze, which is very rare, can also be treated with PTK, and the vision can be restored to normal, whereas it's not as dreaded as the ones which are associated with LASIK, associated with the microkeratom, especially the buttonholing, the free flap. All these complications are not there here. And again, with the SMILE, the lenticle related, when there is a early beginning a learning curve, all these lenticular adhesions and lenticular related complications are not there with the advanced surface ablation procedure. And again, when compared with ICL, it's not an invasive procedure, so the risk of RD or endophthalmitis or corneal decompensation or glaucoma, cataract, glass, and halos are all not there with the advanced surface ablation procedure. So some of the case reports where one eye underwent LASIK and the other eye underwent PRK, and after a few years, it had developed keratectasia on the eye which underwent LASIK, but not in the eye which underwent PRK. So even post-SMILE, we find corneal ectasia, but this is one study done by Damien et al. With a 5-year follow-up on patients who underwent photorefractive keratectomy with suspected keratoconus, but no case of corneal ectasia was reported. Though the study seems to be a tall claim, but a lot of literature searches does show that none of the cases of ectasia seems to develop after PRK, especially if it is done on perfectly normal topo and perfectly normal eyes. So this is a procedure of choice for the patient who put safety first, and for all doctors who put patient first before anything else. And my most happy patients are the post-trans PRK patients after the first 3 days, and they are even happier after a month and happiest ever after. So this is the technique and technology of the masses with excellent results. It's a highly inclusive procedure which can be done on a variety of patients, and it's very affordable and short learning curve, which makes the surgeons very happy and patients happy too, and it leaves behind a truly everlasting smile. Thank you so much.
Thanks for a very detailed talk. While Dr. Nishant gets his presentation ready, I think the other issues which have come now is we've understood that if you give a lot of cold irrigation, the pain component becomes less. We also use a bandage contact lens which is soaked in Acuvale, which is actually nothing but Nevanac, and that we place on the patient's eye after washing it off, and that also seems to address pain. So that, and of course topical steroid drops post-operatively, use of mitomycin C, and mitomycin C usage, some people use it standard 30 seconds for small refractive errors, but if the refractive error treatment is slightly more than -6, we use 10 seconds per diopter, and I'm sure Shreyash will tell us a lot more on high myopia and PRK. So we shall now go on to Dr. Nishant Madhivanan, who's going to talk on topo-guided PRK and TREC and its role in keratoconus, and I think that is the way forward. Now keratoconus has not just become a pathological disease, but we are able to ensure that we are able to give 6/6 to most of these patients, especially in the mild and moderate keratoconus. BCVA of 6/6.
Yes. Good evening, everyone. So thank you so much, Madam and Sir, for giving this opportunity. So I'm sure that Madam has given a detailed explanation of what the Schwind can do with the trans PRK. So I'm just going to say a small thing about how different can we start treating keratoconus patients. We all know the Athens protocol, where we have to ablate around 50 microns of epithelium and 50 microns. So you add up to around 100 microns, including the PTK and the PRK mode. What Schwind does is, it actually refraction optimization happens, and then you can actually decenter the cone. The best part of the Schwind, where you can do the trick, which was actually done by Nara Netralia study, is where it is not only the total regularization of the cornea in what a TCAT or topo-guided treatment does, but a focal laser on the steep part. We all know that excimer flattens the cornea. Why should we ablate the rest of the cornea which is not so steep enough? So this is the Schwind which I use. A small bit about the calculation. So we have two options. One, what a trans PRK does is a fixed epithelial removal in the center. It gives an overall ablation. So the option 2 is trans PTK with PRK. But what about the area of the cone which is going to be little decentered? We know that by doing that, the ablation over the epithelium, which is little thinner than the rest of the area of the cone, is also going to be ablated to the maximum. For example, we know that 55 in the center is actually not going to be 55 at the area of where the cone is. So how do we calculate? After we import the file, so I take the epithelial thickness from the ASOCT which is there. The subjective refraction is over here, and I'm going to talk about the two modes, that is the aberration-free treatment and the corneal wavefront guided treatment. So you can see here that you have different modes, that is the trans PRK, PRK, where the total ablation and the epithelial thickness will be shown in the trans PRK, And in the PRK, you have difference between the epithelium and the ablation. The advantage of the corneal wavefront guided treatment is it also treats the higher order aberrations which are there. I'm sorry. Yeah. So it also so if you take in terms of the aberration free treatment, you have around 96 microns which is being ablated, and in a corneal wavefront aberration you have around 100 microns because it takes care of the higher order aberrations as well. But the best thing is you have something called the manager, where even in the higher order aberrations, the machine calculates which is most important and which is less needed. So you see that this is a filtered mode from what that 100 microns which it used to be, and now after filtering whatever aberrations are really necessary and not necessary, you have only 94 microns. So this is the procedure what I do for the TCAT CXL. I'm sure madam has shown a small video. I just want to highlight what it actually means by touchless. So once after we put the speculum and wash the eye, and you have the debris removal which comes after the focus over the center. So this is all you have to do. So yes, this is truly a flapless, bladeless and a touchless procedure. It takes care of the epithelium and the power in one stroke. So coming to my topic on the trek. So what is the outcomes? So we all know that keratoconus is also giving the patient some visual rehabilitation. If not the quantity, at least the quality of the vision being, even if they're seeing 660, when they actually do the trek, even if they're able to see the same 660, they are having a much clearer outcomes. So this is the study by Roach Shetty et al. Where they have done something called a trek, where it is the topography removal of the epithelium by using trans-PRK. What I actually do is the PRK with C3R, because even if I do an ASOCT, I know that the epithelial thickness over the cone is going to be much lesser than the rest of the cone. So how I calculate is, once the cirrus is done, we have the tangential anterior. You can see that the symmetrical index fringe, this is the irregularity of the fringe surface of the cornea which is shown. I do it for early keratoconus who have at least a minimum thickness of 350 and greater. So after you take, you can see that the K is almost around 4754, and I mark the thinnest location is around 468. So I calculate only the direction of the cone, that is the long axis and the short axis. And the best thing about this is you can decenter the cone. I think no other machine is there which will decenter the area of ablation based on this. So this is how the calculation is done with the long axis and short axis. And this ablation can be variable. It ranges from 15 microns to 20 microns. I keep a maximum of 20 to 25 microns. So in a TCAT, you should know that it will minimum ablate around 50 to 60 microns, which is not the case in this trek. So once it is done, this is actually the image of the Sirius, and you can see this is what my laser is going to apply. You can see how perfectly it is superimposed on the area of the cone alone. I'll just show a small video. I have put some red dots. So once I manually remove the epithelium, you can all watch at this area. Even with the laser at the center, you can see that the laser ablation is hit only at this area. So that is best what the trek does. So it only hits only the area of the steepest portion of the cone by keeping your laser mark even in the center. There are some machines where you can decenter the whole machine, but you can't be very sure and accurate of this. So I have more than 35 eyes which is done. Just want to show a few case scenarios where you can see that this is the pre-operative patient who we have done. And post-operatively, I'm not going to say that they are going to be normal. Just that you can see the amount of area which has been regularized. And this is the anterior curvature which was 9.34 was the SIF, which actually improved to 3.23 post-trek. So you can see the amount of area which has been ablated. So even their vision, I mean, even though I tell them that it's not only for vision, you can see that some of these patients with a cylinder, their vision gets improved drastically. So this is the second case which is done pre-operatively with around 20 microns. I was able to get this within 6 months time. And the symmetrical index friend from 6 decreased to 3.19. So not only that, but their vision also gets improved dramatically. So this is another case where you can see that I did only the area of the cone. I didn't want to do TCAT because the next question is why are we not doing TCAT is because we didn't have so much of stromal epithelium which I can ablate. So this also from 4.5 it has got better to 2.2. So in the logmar when we actually see that it is statistically significant which is less than 0.1. So I am happily able to say that it is not only for the quality, even the quantity of 1 or 2 line improvement is definitely there. So it decreases the impact on corneal irregularities, increases the visual performance, but the major advantage is the lens fitting will definitely get better post trek for these keratoconus patients. Because the only thing what about their fitting is usually they'll say the rose-K lenses keeps falling out, the RGP lenses keeps falling out, and they can keep only the mini-scleral lenses which might be little higher on their budget. So after these procedures, patients are also able to use the rose-K lenses fitting which was not able to be done previously earlier. So my take home message will be that in terms of trek, which is very useful in ablating less tissues, it regularizes the corneal surface, it gives a very good lens fitting and improves the quality of image, and it is very perfect for early keratoconus patients. Thank you.
Thank you, Dr. Nishant, for demystifying complex terms like TCAT, TREC, and for actually Ghostbuster. You're called a Ghostbuster because you reduce ghosting images. Thank you for the nice presentation. And next I call upon Dr. Shreyas Ramurthy, the son of 2 renowned prodigies, yet a super prodigy in his own right. Today he will deliver back-to-back talks on his experiences with trans-PRK and mastering IPCL implantation.
Thank you so much, madam, for the very kind invitation, and it's a real pleasure being here. First time I'm coming to Tambaram, and it's so nice to see such a full hall and so many people listening with rapt attention to all the talks. So thank you once again. So madam said 7 minutes per talk, so I've taken the liberty of trying to fit both together within that time frame of 14-15 minutes. So I'll initially concentrate on talking about the phakic IOL IPCL, and then we'll try to have a discussion about PRK and high myopia. Already we've had a few very interesting talks on PRK, the smart PRK as well. So to begin with the phakic IOL, I think this has been a game changer. Of course, it's here to stay, and it's only increasing in terms of the adoption, the numbers, the indication, the usage, and the threshold for using phakic IOL is actually lowering day by day. It won't be a far off day when we actually sell all our excimer machines and use only phakic IOL as a single mode of refractive modality, because frankly, this particular technology can treat any power, any type of power in almost any type of cornea or any type of eye. So quickly, I mean, this is an old slide comparing ICL and IPCL. Most of you know about the details now. I think one of the points which I'd like to highlight, especially with IPCL, is the range of customization. Any kind of power, any type of patient, you can have the lens manufactured, delivered to you within a very, very few days. Just now, before coming in, I was speaking to Sanjay for a patient with a very odd power, +3 sphere with a -7 cylinder, and he said, don't worry sir, 10 days we'll have the lens sent to you. So even that level of customization, such rare powers is possible with the IPCL. The material itself, there is a lot which is spoken about the Collamer material, but we must understand that Collamer is just 0.02% of the lens. Essentially, that's also a majority of the ICL is essentially an hydrophilic lens. And these hydrophilic lenses are extremely biocompatible. UVL biocompatibility is very good. There's no inflammation whatsoever. And all the lenses nowadays across all companies come with the central hole, and this has become again a very, very important aspect in preventing the development of cataract, which was a major concern with the earlier generation IOLs. Moving on to the way we use the lens itself, that in ICL again or in other companies as well, you have an axis to which you have to rotate the lens. There's still some possibility of parallax error, some problems which can creep in. With IPCL, it's always customized to 0-180. So that really enables you to remove the element of error which can come with manual marking, and you always have it at 0-180. It's very, very easy to place the lens in that axis. The size of the holes doesn't matter as much, but you do have extra drainage holes, larger holes, which help in draining the viscoelastic. It is dispensed in saline itself, and the loading is very, very easy. This is a point again which I want to highlight. I'll show it in another video perhaps, and we'll talk a little bit more about it. The optic size again is very, very important. We all know that the major advantage of a phakic IOL over any refractive surgery is that you can have a very large optic zone diameter. And because of the location of the lens, it's further back and closer to the nodal point of the eye, it is 1.25 times the effective optic zone size than what you would get with your refractive surgery. So even a 6 mm optic gives you 6 into 1.25 for the optic zone, whereas you cannot go beyond 6 or 6.5 millimeter optic zone in most corneas for any kind of refractive surgery that you're doing. And you also have customization in this. You can have, for patients who have a larger scotopic pupil, where you really are limited with options when it comes to refractive surgery, you can have customized lenses which give you a very large optic zone for even patients who have a large scotopic pupil, to completely avoid and obviate issues of glare and halos. Again, the IPCL has several haptic pads. They have 6 ciliary pads or haptic pads which rest on the ciliary sulcus, and the lens is extremely stable and again does not rotate very easily. This is a brief video about just showing the lens itself. You can see that apart from the holes, you see a small knob which is there on the leading left and another knob on the trailing right. This gives you the orientation of the lens, and these 2 holes, draining holes, which will remain superior, essentially so that they are covered by the eyelid. Even in a dilated pupillary state, they will not cause any edge effects or glare. The loading itself is extremely simple. You can load it with just saline, and after you put the saline, you just place the lens, and it's a simple butterfly cartridge. You take it and orient it in the right direction, just tap it down and close the lens. It's extremely simple, and because the loading is simple, it's easy to deliver the lens and easy to ensure that you're delivering it right every single time. Whereas with the ICL, you still have a little bit of a learning curve when it comes to loading the lens. You have to ensure that you're holding it in the right direction, pulling it with the right amount of force. Surgery, again, very simple. There are small variations which you can bring in. You can do with 1 side port, 2 side ports, no side port at all, just a main incision also. Anything can be done. And various types of viscoelastics can be used. I'm quite comfortable using just HPMC. It's more than enough for this lens. This IOP spikes and other things are almost non-existent. I mean, you are able to, even if you are not able to drain out the entire amount of viscoelastic from behind the lens, it's still okay. These are young patients, they drain very easily. The very next day, the IOP is quite normal. The opening of the lens is very predictable because the loading is easy. You have it in the right orientation. You can just tap it down, use an instrument and tuck it behind the plates. IPCL again is very, very pliable, and therefore it's very easy to bend it and tuck it. Even if your pupil is not well dilated, even with a 5 mm pupil, you will be able to tuck it in very easily because the lens is very, very pliable and it can be positioned. Again, rotating the lens is also not very difficult. Unlike a toric IOL, we can even rotate it with the viscoelastic inside and then remove the viscoelastic. Because of the lesser amount of space, these lenses don't rotate even after you have removed the viscoelastic, and there's hardly ever a requirement to go in and adjust the lens again. Sizing is perhaps the single most important criteria and the only criteria that you need to pay attention to. And measuring the wide to wide diameter, identifying the middle of the limbus from one limbus to the other limbus, either with your slit lamp or your under your microscope, ensure that you have the right sizing. If you have the right sizing, I think 90% of the job is done because the surgery is extremely repeatable and fairly easy. Again, one of the areas where IPCL really scores over other companies is because they have lenses at 0.25 steps and are able to give you from a very low to a very, very large overall diameter, and therefore you can actually customize based on the type of white to white that you have. When you're limited by choices, a small 0.1 to 0.2 millimeter variation in your white to white measurements you will be forced to take a larger lens, which is about 0.6 or 0.7 more, and therefore you may end up with a slightly higher vault. Whereas with this 0.25 steps, you can really customize it, narrow it down, use it even in lower anterior chamber depths, because in those patients you can even choose one step lower, that is choose a 0.25 mm lower and still have an adequate vault. Another very, very important point which I forgot to mention with the earlier design of the lens, it has a very nice mid-peripheral rise, and because of this mid-peripheral rise, even in patients who have a slightly smaller lens, you don't end up with a low vault. You still have an adequate vault even in patients where you have by mistake or by choice selected a slightly smaller lens for that particular eye. This is just an example, not that, video is not running. Yeah. So this is a patient where the toric ICL kept rotating, and when we did the measurements again, we realized that we need a 14.5 diameter lens, and this was not available with the ICL, and therefore we have exchanged the toric ICL with a toric IPCL, where you can get it customized at a larger diameter. This was a patient with a unusually large white to white diameter, and this is a 14.5 millimeter lens, which is diameter lens, which is going in, and therefore the stability of the lens is also extremely good. Again, exchanging the lens is very, very simple, and like I mentioned, you may end up with a low vault, but thanks to the center of flow, even vault as low as 130 microns as in this patient, and this is an eye with 100 micron vault, you can safely observe them. The cataractogenesis is extremely rare even in these patients. High vault is a little bit more of a problem, and this is something you want to avoid. I would rather err on a side of having a slightly lower vault. Like I've already mentioned, the rotational stability is still good even if you're with a low vault. But then occasionally if it's rotating, yes, you may have to exchange it with one size larger. But you would want to err on the side of a lower vault than having a higher vault, because higher vault again over a period of time can cause angle issues, and if your angle opening distance is below a certain critical level, it's better to exchange it with one size lower when you end up with a high vault like this, which is 1200 micron in this particular patient. So again, sizing, use different equipment. There are multiple options which are available, a variety of ways with which you can measure the white to white and corroborate the values of white to white, because this is the single most important value which is finally going to help you with the outcome of the procedure. Again, exchanging of the lens is very simple. Technique which I like to use is, after you dilate the pupil, just pull one foot plate out, and once one foot plate is outside, you can just grasp it with any small forceps, which is easy, so that the AC doesn't collapse, and then using a slight hand over hand technique, it comes out very easily. It's a very pliable lens, and then you can go ahead and inject another lens. Again, cataract is very rare nowadays. This is an old lens which was before the center of flow was given, and you can develop this typical anterior subcapsular cataract. Suffice to say, it's fairly easy to remove the lens, as you can see, and you can remove it through the same 2.8 millimeter incision, and then subsequently you can go ahead with your cataract surgery. More often than not, it's usually a soft cataract, and it's just an anterior subcapsular cataract which has happened because of the lack of central flow. The aqueous distribution is not good. The nutrition to the lens itself is affected. This is a paper which we published about 8 or 9 years ago, looking at the initial long-term safety of posterior chamber IOLs with a minimum follow-up of 3 years, where we showed was a very safe and effective treatment. Again, this is comparing IPCL and ICL, and both had a very effective outcomes with similar efficacy and safety profile, and of course, economically a more viable option by using the IPCL. Going beyond the regular correction of refractive errors for correction of presbyopia as well, you have these trifocal phakic IOLs which are also available, and these lenses have a typical defocus curve quite similar to that of a trifocal lens itself and give an excellent range of vision. And you have 5 variants which are available. So based on the age of the patient, you can actually choose whether they are in their early 40s versus late 40s or 50. You can choose a different ad power based on their age group. What we generally prefer to do is to use a lower ad for the dominant eye and use a slightly one step beyond what they actually require for the non-dominant eye. And this works extremely well because even for the next 8 to 10 years, this patient is able to manage without any type of requirement for glasses. And one very nice thing is, even though it's a diffractive lens, because of the way it is positioned, it's quite close to the pupil, these patients don't face the same amount of glare and halos or the photic phenomena which they have with a regular multifocal intraocular lens implant. These presbyopic phakic IOLs, the patient hardly, you don't even have to counsel them for glare and halos, they hardly appreciate the glare and halos. Going one step beyond to another indication, which is keratoconus itself, where you are expanding indications for phakic IOL usage, and this has now become a routine. Wherever the patient has a very good best spectacle corrected visual acuity, they are happy with their spectacle vision, have never worn contact lenses in the past, so don't really know how the contact lens vision is, don't want to wear contact lenses, have 612, 6.9 or better and are happy with the spectacle corrected vision. They are excellent candidates for phakic IOLs. And this is a series study which we did. For some patients who had a little more irregular cornea, these patients underwent intacs. There was a better improvement in their spectacle corrected visual acuity. And once the spectacle corrected visual acuity improved, we then went ahead with a phakic IOL. So as you can see here, the Kmax is fairly high. It's 54 in this particular group. And what you must see here is, I'm sorry that the font size is a little small for the rows behind. 90% of patients were within plus or minus 1 diopter and 80% were within plus or minus 0.5. And these are keratoconic eyes, where even your spectacle corrected visual acuity, spectacle prescription itself can be off by plus or minus 0.5 diopter. These are excellent outcomes for a patient having keratoconus. And especially in patients who have a higher degree of anisometropia, where one eye is an early keratoconus, other eye is an advanced keratoconus, or rather the refractive error is higher, this is a very good option. Or a patient has undergone a topography guided PRK or has undergone an intact, subsequently spectacle corrected visual acuity has improved, they can do it. Even patients post-transplant as well, this can be used. Especially if it's a DALK, you can definitely go ahead with a phakic IOL lens. One very important thing is that because you're correcting the amount of anisometropia and more importantly the anisoconia that these patients can have, 40% of patients had a gain of 1 or more lines in best corrected visual acuity, which again is very impressive considering the situation that they are in. We compared low versus high astigmatism, and even in patients with greater than 4 diopters of astigmatism, the outcomes were similar to that of low astigmatism. Comparing again ICL and IPCL, again the outcomes were very similar. We also looked at centered versus decentered cones. Typically we say in centered cones the phakic IOL works very well. But even in decentered cones, when the patient is well adapted to the cone, has a very acceptable spectacle corrected visual quality, they are happy with the spectacles that they are using, phakic IOL can be an excellent option even in decentered cones. And yes, the size of that subset is smaller, but then the outcomes are very similar between both the groups. One thing you must be aware of in keratoconus is that because of the central steep corneal curvature, you will have a falsely high anterior chamber depth. So you do well to choose one size lower than what you would normally choose for that anterior chamber depth, because some of these patients can have a slight optic capture because of a higher vault if you choose the same ACD that the patient is having and choose the same size lens for that ACD. So one size lower works extremely well. Just an example of a patient in keratoconus post-intacs who had this kind of optic capture because we went ahead. Now as a routine, we choose one size lower and we've stopped having this problem of optic capture, and the vault is also very acceptable. Just an again example of a patient where exchange was done for inappropriate sizing, slightly higher vault in keratoconus. This has become extremely uncommon after we have selected the nomogram of choosing one size lower, and we seldom have these complications anymore. But just again, it's very, very simple that even if you do end up with such a situation, you can exchange with one size lower, and these patients do extremely well. So appropriate case selection and patients with satisfied with their best spectacle corrected visual acuity and giving importance to the sizing gives you optimal results even in these patients. You can use them post dark situations also, again where the patient has a good spectacle corrected visual acuity. Some of them will have a lot of anisometropia, may not be able to wear glasses because of the anisometropia, and this is a very good option. You can also use it in situations where after a cataract surgery that the patient has a higher amount of residual error, and you can use this as a piggyback lens. Again, these patients will anyway have a larger anterior chamber depth, so you don't really have to worry. You have enough space in the ciliary sulcus, and then you can go ahead and implant a lens. And this was a patient who had undergone a cataract for developmental cataract at a pediatric age group and had gone on to develop a significant error later in their life. And after they were 20 years of age, this phakic was done and gave very consistent results. So again, IPCL, phakic IOL is a safe combination, and for any error, whether it's myopia, hyperopia, astigmatism, presbyopia, even in keratoconic patients, works extremely well. Thank you so much for your kind attention. I'll just quickly move on to high myopia PRK and hope to have some discussion on this. This I'll keep it very brief. I've not, it's more of what literature has to say about PRK and high myopia and what is really the consensus, whether we want to do PRK in high myopia. Is it really necessary to do PRK in high myopia? Is it safe to do PRK in high myopia? So one of the challenges, I mean, you do come across these challenges in across different study groups, but then again, the meta-analysis for high myopia is not many, of low quality. You have less of RCTs. Again, the uniformity in reporting outcomes also very variable. Even the way the studies have defined high myopia, some are 6 diopters, some are 8 diopters. So there are some hurdles when you try to do a literature review. But then let's look at the pros and a few of the cons of doing PRK in a patient with high myopia. So when it comes to efficacy, there are a couple of studies which have compared high myopic PRK versus low and moderate myopia. And at 1 month and 3 month outcomes, the efficacy of the outcomes of a high myope versus low and moderate myopes is the same. And with the modern day lasers, as madam already alluded to, with the smart surface and other platforms which are available, you have extremely consistent outcomes. And it's similar or better than even LASIK in some cases with regards to the efficacy. Safety, yes, there is a risk of haze. With higher ablation, deeper ablation, you are at a higher propensity for developing haze. But with the longer duration use of mitomycin C, even this can be obviated. The risk of haze, even in these eyes, in reported outcomes, ranges between 1.5 to 4.5% of visually debilitating haze. That is, subtle haze where the vision is still 6.6 is fine, but where there is loss of lines of BCVA is still only between 1.5 to 4.5, even in long-term outcomes. Again, since you're not affecting the subbasal nerve plexuses and the lesser nerves are being transected in a PRK, there is a lower incidence of dry eye in PRK than compared to a high myopic LASIK. There was already biomechanical strength has been alluded to. PRK is definitely better than the other platforms when it comes to biomechanical strength. But then again, does it really warrant a change in the way we do our screening criteria? Not really. If a patient is not fit for a refractive surgery, you would do well to just go ahead with a phakic IOL than to take a chance by doing a PRK, especially when we are talking about high myopia. Low myopes, yes, with PRK you will definitely be able to get away with it more often than not. Longer healing time is really one of the major concerns with PRK. The visual recovery is slower. Again, visual recovery is not much slower. It's slightly slower in studies which have actually looked into this. It is slower by a few days on a mean when you're looking at it, when you're correcting higher powers versus lower power, but it's still insignificant. transepithelial, because of the way the transition zones are, the epithelialization happens faster. So it's averages between 2.5 to 2.7 days for a transepithelial versus 3.5 to 4 days when you do a manual or alcohol assisted epithelial removal. One major problem which you cannot obviate is the incidence of regression. So 25% of patients will develop a diopter or more over 5 years. And that is a fact that we have to contend with whenever you do a keratoablative procedure for any patient with a high myopia. This is one thing which we cannot overcome. The epithelial remodeling is also higher when you do a higher myopic ablation. You're often forced to do a slightly smaller optic zone than what you would do for a low power. And these are patients, again, who are going to have a higher amount of regression. So this is a significant disadvantage when it comes to a keratoablative procedure. So to really conclude this discussion is efficacy, predictability, yes, is similar. Longer healing time is something you have to contend with. Tackling regression. So while you may say that if you have done a high myope, leaving a small or getting back a small residual error or rather a small regression is something that the patient may not be completely unhappy with. But are you really wanting to replace a thick glass with a thin glass? Is that the desired outcome of a refractive procedure? Or would phakic IOL be your only choice for all these high myopes? Frankly, in today's day and age, I think it's possibly the only reason for doing PRK in a higher power or even LASIK or SMILE in a higher power would be for financial reasons. And PRK for, obviously we can do it at a lower cost. But if the patient is able to afford it, more often than not, phakic IOL would probably be the choice that you would use for any patient who's moderate to high myope. Thank you so much for your attention.
Thank you, Shreyash. That was both the talks are very highly eloquent talks, and we had learned so much in your talk. There's one question. Nishan did talk well on topo-guided PRK and TREC. I want your thoughts on that. Would you consider doing TREC for thin corneas where you can't do a topo-guided PRK with cross-linking? And since we know that topo-guided cross-linking, the BCVA and the UCVA is better than in TREC. What are your thoughts on that?
So when you don't have enough tissue to do topo-guided PRK, or it's probably too advanced to do a topo-guided PRK, rather than doing only CXL, TREC is a viable option. Because of the small optic zone that we are choosing, even for a very low amount of ablation, you have a significant amount of flattening. You can get even 8 to 9 diopters of flattening with just 20-25 microns of ablation. And that definitely improves the overall symmetry. Where we have seen that the patients have best outcomes is when they have a very high IS asymmetry, not really in symmetric cones, but where patients have a very high IS asymmetry, you can decenter the PTK, ablate it over the area of the maximum steepening, and that definitely improves the overall topographic outcome and significant reduction in the IS asymmetry overall.
Thank you. We shall go on to our next speaker, Dr. Seema, who's a senior cornea consultant from Arvind Eye Care Systems, and she's going to tell us how we could smile all the way. On to you.
Good evening, everybody. At the outset, I'd like to thank Dr. Kavita Lakshmi for inviting me for this talk. A very nice gathering here. Being one of the last speakers, I have the advantage of hindsight. I've gone through so many speakers here. My disclaimer would be, being a refractive surgeon, we have the benefit, not just refractive surgeon in ophthalmology modern day, we have the benefit of choices of technology. So the question is not whether you'll do microkeratome, or you'll do femto, or you'll do PRK, or you'll do SMILE. It's just that we have to assess the pros and cons of each kind of technology that we have, and make the best of it and give the best kind of treatment for our patients. So smile all the way doesn't really mean smile for all the patients. It just means that we are going to see how smile has come all the way till here and how it is going to progress in the future. So this is a short history of refractive surgeries. First, we had excimer laser surface ablation. PRK was one of the first excimer laser treatments to be started, following which we had the microkeratome LASIK. Following that, in the early 2000s, we had the femtosecond-based LASIK, which made LASIK overall much safer, eliminating flap complications to a great extent. And then in the later half of the 2000s and closer to 2011, we had Relax Smile. Smile is nothing but small incision lenticule extraction. So when earlier days we had these studies and experimental model of porcine eyes where you see the lenticule. So what happens in Smile is it's an all femto laser. There is no excimer laser involved at all. So they used to, the early experimental days, they used to make the flap and make the lenticule under it and remove the lenticule and study how it works. Then we came to the small incision mode where we make a very small incision of about 3 to 4 mm through which we are able to extract the appropriate thickness and shape of the lenticule, which will reduce the power of the patient's refractive error. So this is a short video for beginners and trainees who would like to know what Smile is all about.
Smile, known as a minimally invasive and flapless surgery, is the
We can
third
switch off the audio
generation of
here.
vision correction beyond PRK.
So basically you see that Smile, there is a two-planar laser which is fired. The femto happens at 2 levels. One is the posterior plane and then is the anterior plane. These 2 planes are connected to each other. This forms a disc within the cornea, and then through a very small incision, we are able to dissect this disc and remove it, thereby reducing or flattening the curvature of the cornea. So these are the parameters that we look at when we are doing Smile. So in Smile, like I said, there are 2 planes. So we are talking about the posterior plane, which is called as the lenticule plane, and the anterior plane, which is called as the cap plane. So the lenticule, do we have a pointer here? Either. So the screen on the left shows the lenticule highlighted. So you see that the refraction of the patient's sphere, cylinder, and axis is fed into the system. It shows the correction. And in LASIK, when we do excimer, we talk about optical zone. In Smile, the optical zone is nothing but the lenticule diameter. So if my diameter of the lenticule is 6 mm, that is the optical zone I'm treating. If it is 6.5 mm, that is the optical zone I'm treating. In addition to that, I have a transition zone. This transition zone is a 0.1 transition zone applied only when patients are having astigmatism, not pure myopia. Then you have something called minimum thickness. This minimum thickness gives us the added advantage of thickness to the lenticule so that the dissection and later on extraction of the lenticule is easier. If the lenticule slides to the periphery in such a way that it is very thin at the periphery, there is no significant tissue to hold that, then we will not be able to remove the lenticule without complications like lenticule tear. So this minimal thickness is to avoid that. And then you have something called a lenticule side cut angle. So the lenticule side cut angle means the lenticule connects to the cap. This is at 90 degree, or you can set it accordingly. Most preferred is 90 degree. Then we come to the cap parameters. In cap parameters, apart from the corneal radius and pachymetry, we feed in the treatment pack. Treatment pack is nothing but the cone that you use for doing the laser pass. So small is the size that we use preferably in most Indian eyes because Indian eyes have smaller diameters. And then you have the cap parameters. So the cap parameter being 7.5 in this case, where the lenticule parameter is 6.5. We oversize the cap by 1 millimeter over the lenticule. Then we have the thickness of the lenticule. So this is something like your flap thickness. In LASIK, you have flap thickness. In Smile, you do have cap thickness. And then the angle of the side cut of the cap. The side cut of the cap is nothing but the incision through which you remove the lenticule. So that is the angle. You may have more than 1 incisions also. There are surgeons who prefer to do 2 or sometimes even 3 incisions in smile surgery, but most recommended would be a single incision, which is usually for a right-handed surgeon. If you keep the incision either at 90 degree or a little to your right, it works better. So my preferred site would be around 110 degrees. So these are the parameters again in short to show you that 1, which is highlighted in green, is the lenticule. 2, which is highlighted in red, is that part which connects the lenticule to the cap. 3 is the cap. And 4 is the final incision through which you're removing the lenticule. This is, in short, the steps of the procedure for smile. First, you will check your centration using an infrared imaging, that the treatment area is well centered on the pupil. Then you start firing. Once the suction is on, you start firing the laser. The first step is where the posterior part of the cut is made, that is the lenticule is made. This is spiral inwards, outside to in, because that is going to be the posterior part. Now you have the side cut which connects the posterior part to the anterior part. Then what fires is the anterior part or the cap. Once the cap is completed, the last part which fires is the incision. So we'll just go through this. A short video to take you through what steps you should follow before you start firing. Make sure you wash off all the debris. Excess mucus or excess meibomian secretions should be removed. Following which, it is very, very important to dry out the conjunctival surface completely. It is important because this is a corneal suction. This suction that we use in smile is a corneal suction. You see the cone getting docked there. It is going down, and now slowly as you dock it, there is no suction ring involved here. It's just the cone which directly applanates the cornea. So you have to make sure there is no residual fluid. The cornea should be just moist, not overly wet. And then once you dock, you generate the suction. So this is, again, as the cone was going down, this is what the surgeon would see through the microscope. The cone is going down, the white ring is seen, and the green blinking light is what the patient is going to perceive. Now, as you keep going down, you'll start seeing a small applanation meniscus. This is a circular meniscus, and you have to make sure that the green spot now lies at the center of the circle. Once you see, you start expanding, and then you dock. When the suction is on, the laser starts firing in the order of posterior cut first. Outside to in, the posterior cut or the lenticule cut is now being made. As it reaches, now look at the periphery. You can see the side cut of the lenticule being made. Now, inward out is the cap cut that is being made at this point. Once the cap cut is completed, look at the 12 o'clock, you have the incision cut being made. So this is the part of the laser. Now is the part of the surgical dissection, that is the lenticule extraction, where we first delineate the anterior plane, and then we delineate the posterior plane. The important thing is that during laser fire, the posterior fires first, but during extraction, we dissect the anterior first. Obviously, once the anterior laser is fired, the posterior cannot pass through a hazy cornea. Here is where we are dissecting the anterior plane with a spoon-like blunt dissector. So the anterior plane, we dissect from side to side throughout the 7.5 mm or whatever we have created. Once that dissection is complete, you will enter the posterior plane. The posterior plane is dissected through the center and mid-periphery right to the 6 o'clock. Surgeons have different preferences on how they do it, but we prefer to keep 2 hinges left on the 3 and 9 o'clock to be dissected last, so that the lenticule doesn't curl on itself before it is removed. And finally, when you have completed the dissection, you have a pair of microforceps that you introduce to remove the lenticule. So this is about the procedure of smile. But every surgery, as we have discussed so far, is not devoid of complications, and so is the case with smile. We may have some of the complications like intraoperative or postoperative. You may have lenticule creation related complications such as suction loss, OBL, opaque bubble layer, black spots. Subconjunctival hemorrhage, though, are much rare with a corneal suction. Lenticule dissection related complications would be an incisional abrasion, which is very common usually if you're trying to open the incision, or the more, serious complication would be an unintended plane of dissection or a false passage. It may so happen that the lenticule is not clearly separated, and when you're trying to overly dissect the area, you may end up creating a cap false passage into the cornea into a different plane altogether. There may be a very adherent lenticule, which you may not be able to dissect easily. Then you may have tears or remnants of the lenticule within the pocket, which may not help you to correct the refractive error. It may induce astigmatism. So these are the intraoperative complications. You may have some postoperative complications, which are like similar to LASIK, but we know that dry eye is supposed to be much less in SMILE as compared to LASIK. So this is a quick video about something we call as black spots, which is peculiar we see in SMILE. Here I would like you to see, once the docking is over and the infrared is on, now I'll just zoom and pause here a bit. Can you see those areas? These are some meibomian secretions which are probably still there. So the laser which is firing is not able to completely penetrate through that area, because mind you, SMILE is a low energy laser. So you see these black spots getting generated in this area. These are the areas in the posterior cut where the laser has not passed clearly. This is called as black. So I'm directly going to the posterior lenticule dissection, where you see that the other areas are dissected, but that particular area, I'm finding a great deal of difficulty to dissect that area. I switched to a narrower dissector here, and then finally over 8 to 10 minutes of dissection, I'm able to remove the lenticule. Obviously, in cases which have more manipulation like this on post-operative few days, you might have more corneal edema, for which we will have to tackle these patients with steroids. But overall, it was a fairly good recovery at 1 month post-operative period. Now, this is another case where you have a docking happening here. Watch closely once the docking is happening. The patient was, this is another colleague's video here. The patient is uncooperative in this case, and is, despite instructions, is trying to move the eye. You see the laser is firing here, and the patient's moving upwards towards the 12 o'clock. Now you see the angle at which the side cut is beyond the lenticule itself. The side cut has passed at a different area, and then there is a suction loss. So you see the anterior cut has not been completed here. This is another case where there is something called as a pseudo-suction, which is not a true suction loss, because when a true suction loss happens, the laser stops firing. Here, the laser did not stop firing. So, you see the posterior lenticular cut. There are small movements of the patient's eye beam happening. Look at this area. Towards the 12 o'clock, there is conjunctiva getting sucked in. As the laser is passing, conjunctiva getting sucked in, and the anterior cut is being made on an opaque area of the cornea, which means this area will not be open at all for dissection. So in this case, a lenticule, the incision cut did not get formed at all because of the pseudosuction. So these are rare complications. In case of SMILE, the suction loss may be a complication for which you have to counsel the patient very well not to move their eyes and not to squeeze their eyes. More so because femtosec and LASIK, if we are used to that, it's a very scleral and very rigid kind of suction which doesn't really give up so easily. So patient counseling is very important in these cases. Comparing the complication rates of femtosec and LASIK versus SMILE, I would say that flap-related complications are about 0.3 to 3.6% in literature. Similarly, when you come to SMILE, you have difficult lenticule extraction, which is the most difficult complication, 1.8 to 9%. But the rest of the complications like suction loss and epithelial ingrowth, these cases are seen with both LASIK as well as SMILE. The one advantage we have with SMILE, though, is you can restart the treatment if it stops in between. So what would be the reasons you may want to restart the treatment is if there is a non-intentional cause or if there is an intentional cause. A non-intentional would be something like a suction loss, which we just saw. An intentional would be eye movement is happening but without suction loss. The second case where we saw the conjunctiva getting sucked in, the laser did not stop firing. But you may understand that there is a problem happening and you may stop the laser pass. In these cases, you may want to restart the treatment. So you have the option of restarting the treatment, which means the software will tell you at which point actually the treatment has stopped. So for example, if the treatment had stopped during the, so you have lenticle cut, side cut, cap cut. 45% of the cap cut was completed and then the treatment stopped. You will be in a position to perform cap cut again. So you can perform the cap cut again and then do the incision cut and complete the surgery. So this is an option that you do have with SMILE. There is another interesting option that you have with SMILE is something called as a circle program. This is a program which is used to convert the SMILE cap into a flap. So where do you want to use this? Converting a SMILE cap into a flap. So in case patients have undergone regression and are coming for enhancement or retreatment, in SMILE we don't have the option of doing retreatment with SMILE itself. So in such cases you may want to convert. What will happen is you will make an annular ring beyond the area of your cap, and that ring will connect to the interface of SMILE. This will help you to make, and then you make a hinge like a LASIK flap in a nasal or a superior side that is of your preference, and you lift the flap. By lifting the flap, you will be able to retreat this patient like a LASIK patient in case the patient has future regression. Also, this is useful in cases it has been reported of epithelial ingrowth. Now, imagine if you have an epithelial ingrowth in a LASIK patient, you can always go back, lift the flap, and debride the ingrowth area. But in a SMILE patient, it is very difficult to re-enter that plane and easily debride that area. In such case, you may resort to this circle software, lift the flap, and clear the epithelial ingrowth, treat with mitomycin, and complete the treatment for the patient. There are advanced systems apart from the Visumax 800 SMILE Pro, which has come now recently. You have the ATOS with Schwind, the Elita Silk with Johnson & Johnson, and the Femto LDV Z8 Clear with Zimmer. So these are the current systems, each citing their own advantages, but the rest are fairly new to the market. We have to yet wait and watch. So what are the limitations of SMILE? SMILE by default is not indicated for hyperopia yet. Pure cylinder is not treated with SMILE. An astigmatism of a greater power of more than 5 diopters will not be treatable. Myopia greater than 10 diopters is not recommended, or a spherical equivalent of more than 8 diopters is not treated with SMILE, or not recommended to be treated. These are the key points that would be the take home. Femtosecond, LASIK, and small incision lenticle extraction are both safe and effective procedures. But there are certain specific scenarios which may render one more beneficial than the other. SMILE is said to be superior in highly myopic eyes due to a smaller decrease in the functional optic zone. SMILE induces lesser spherical aberration. So the induction of higher order aberration is found to be much lesser with SMILE. In low to moderate myopic astigmatism though, femtosecond LASIK has shown to be scoring over SMILE. So this is the latest review article in 2024 July which has been published. So it has taken into account all the previous studies so far. So the advantages of SMILE are its flapless, the LASIK-like recovery, no discomfort like PRK. But again, the advantage of PRK of being flapless is contributed by SMILE. Preserving the biomechanical corneal strength, there is a lot of back and forth in literature about this, but we do have to wait and watch for further studies. Low enhancement rates and attenuation of side effects such as dry eye. There is a disadvantage too, there is a steeper learning curve. There are potentially sight-threatening complications, but there are with other forms of laser vision correction also. We are still waiting to see better innovations in the retreatment and enhancement of SMILE. Same is the case with cyclotorsion compensation, which we do very easily with our excimer laser, not so easily with SMILE yet. We do have the 800 version, which is helping us with cyclotorsion in a semi-automatic manner. Visual recovery in the post-op period is slightly slower because of all the dissection. And SMILE is still an infant compared to LASIK, which has a lot of literature. So we'll definitely have a lot of new innovations in the field of SMILE to come. So to summarize, what I would say is, in a high myope of -6 to -10, SMILE would be recommended by literature. Eyes with low to moderate myopic astigmatism, LASIK also scores well. High astigmatism both have a tendency for undercorrection. Hyperopia, it's definitely, if you're doing, you go for LASIK. Eyes with higher order aberration, both SMILE and wavefront guided or topo guided LASIK. The induction of higher order aberration is less with SMILE, but you cannot correct the higher order aberrations which are already present with SMILE. And pre-existing dry eye, you would want to err on the side of SMILE. So this is the summary or the comparison of both. There are some special cases of use of SMILE lenticules, such as an add-on procedure in keratoconus where you have femtosecond the lenticule insertion technique to increase the corneal thickness. You have SMILE lenticule assisted C3R, where you're doing C3R along with, instead of a contact lens, you use a SMILE lenticule, and in thinner corneas, you still go ahead and do a C3R. The lenticules can also be used as patch grafts or for glaucoma drainage devices. So that's my time for SMILE today. I hope you are all left with a smile to understand all the various options of refractive surgery that you have and are in a better position to make your call. Thank you.
Thank you, Seema. That was a very eloquent talk, and I truly enjoyed it, and all of us did. So we go on to our last speaker, Dr. Arvind Venkatraman, who is again a leading cataract and refractive surgeon from Vision Care Eye Hospital, and he's going to be talking on expanded indications of phakic iris.
Dr. Arvind Venkatraman is a prolific and very fast cataract and refractive surgeon, and he expands his center from Kumbakonam to Chennai, and he's here to talk on expanded uses of phakic IOL for keratoconus.
Okay, good evening, almost we are at good night. Okay, so I want to finish up very fast some of those things which are already been dealt with. So there are some special situations where you can use phakic lens. One is keratoconus, the other is a post-cataract surprise, you can use a lens. Post-laser refractive surgery for undercorrection or overcorrection, you can use ICL. So post-intacs you can use, post-keratoplasty you can use, and presbyopia you can use. So these are the lenses. So, but when you look at it, there is keratoconus, the left eye seems to be okay, the right eye seems to be keratoconus, we all know that. But little bit more than what has been already dealt with, I'm just going to focus more on the keratoconus and some important things which you need to know. So this is an irregular cornea. So can we use it regular astigmatic correction on an irregular cornea? Yes. For that there are 2-3 things we need to do. So there are 2 things. When it is a centralized cone, if it is a centralized cone and the astigmatism seems to be, central, then we can tend to use ICL in a much better way than a cone which is more eccentric. So what happens in a progressive keratoconus? No, we are not supposed to use in a progressive keratoconus. So the most important things are stabilize the cornea first. So you use C3R and then the TCAT procedure. So you smoothen the cone or you decrease the amount of higher order aberrations on the cornea so that you have a better correction with your phakic intraocular lens. So I have used this TCAT procedure a lot in my practice recently in the last year or so, and it has been giving great results. So when you do the C3R, what happens is that we have done the C3R, the cornea remains the same. So there is not much of a change. Maybe over a period of year or so as the scarring gets formed, there may be some changes, but there may not be a huge difference in the keratoconus passion. We don't want this to happen and we don't like it. So what happens in the patient where I can do a TCAT with the C3R? So you have a keratoconic patient, the same keratoconic patient. If we do a TCAT procedure, the patient ends up being like this. So this is a more regularized cornea, which is almost like a normal cornea, which we can manage, with a phakic intraocular lens. So the issues are in a keratoconus, the stability, refraction, anterior chamber depth, and white to white. These are the things which we need to look at. Stability, more than that, I want to look at only 2 things which people need to think about it. You can use it in keratoconus is one thing. The question is what refraction do you need to use? So whether you can use the manifest refraction straight away, and what cylinder are you going to correct, whether it is based on your auto refraction or going to be on your topography. The most important thing, The ideal patient will be, it's not just they are used to correct it with glasses. If your manifest refraction and keratometric axis are the same, those patients are good. Especially if you look at the keratometric axis in the central 3 millimeter zone and then the axis of the cylinder with which you are correcting the patient, if these align with each other, then that patient, even if it is an eccentric cone, even if the cornea is irregular, that patient will be a good patient to do a phakic lens. But if the manifest cylinder and the cylinder on the, the axis on the simulated K values are different, beware, that patient may not be a good patient. Because when you do the refraction, they might do very well, and then you put in the intraocular, the phakic intraocular lens, the patient will not accept it. Because the axis of manifest might keep changing in these patients with intorsion and extorsion, and they may not be a very happy patient. So look at the axis. If the patient is having different highly variation axis on the 3 millimeter, 5 millimeter zones, then also beware in these patients. Don't go with the phakic intraocular lens unless the patient has been treated with a TCAT procedure or a similar procedure, so that we regularize the cone first. So this is a very, very important point, take home point. You can do it in keratoconus, that's fine, but refraction is very important. Even in refraction, look at the manifest axis and the simulated K. Also the simulated K in 3 millimeter and 5 millimeter zone. If somebody's pupil is large and their SIM-K in 3 millimeter and 5 millimeter zone are different, please don't do it. Those patients will be very, very unhappy. So if you look at the other thing is anterior chamber depth. If you look at the anterior chamber depth here you see that it is a very big cone. This is only 2.86, which is bare minimum for phakic lens. 2.8 is the bare minimum for a phakic lens. So you can see that it is only 2.86. As Shreyas mentioned, the cone is bulging outward. We are looking at the anterior chamber depth in the central area. So this 2.86 may be an exaggeration of the actual anterior chamber depth, which may be much lesser. This patient, we may be in trouble if we do the lens. So here I will give you an idea. If you have a pentacam or this thing, you can look at the iridocorneal angle. In one patient, it is about 67 degrees, and another patient, it is 39 degrees. So if this patient has 67 degrees, that means that it's a wide open angle. In this patient, you can very well go ahead and implant, phakic intraocular lens. And one more important thing in keratoconus is you want a good vault on the phakic intraocular lens, because you are correcting a higher cylinder. So you don't want the lens to rotate. If it's going to rotate by 10 degrees, you are going to lose 30% of your astigmatic correction. The patient is going to be unhappy. If it is going to rotate beyond 10 degrees, the patient will have a massive decrease in vision on higher order aberration front, so the patient will not be unhappy. So one way of looking at it is not the central anterior chamber depth, also use these machines to look at the peripheral iridocorneal angle or do a good gonioscopy to see if it is wide open to use the intraocular lens. So TCAT versus corneal ring, if the corneal thickness is adequate, I would say TCAT is a very simple procedure, very effective procedure. So no extra complication, no foreign body or no allogenic material, no long-term complication. I don't want to go into the video, so it's for the sake of time. So the tip for success is toric lens is a great option in patients with keratoconus. As I told you, look for manifest and tomo axis. If you want to do a lens in a keratoconus patient, at least the patient should have 618 and above vision, so that they will relish the vision post phakic lens. If there is a corneal scar in a patient with a phakic lens, without a hole will be better. Remember, you can ask for a lens without a hole. Because I have seen in recent times, like when I am correcting, patients with phakic lens, they have glare and halos because of the central hole. So if you want to do it in a patient with a central scar or, ectatic patient, we can always do a lens without a hole. I think it is a much prudent idea because I have tried it in one patient. So another thing is mark the cornea and the slit lamp, very important. Preferably before dilatation, before implanting the toric intraocular lens. Again, the error has to be bare minimum, because if you place the lens in a wrong axis, and there is a small rotation on your same side, then you have done a self goal. Look at the corneal reflex, and the pupil center should be assessed because we don't have a long angle kappa. The sizing should be careful. As I told you, artificial anterior chamber depth will be deeper. So thank you very much. I don't have time to go into other special situations, and everyone wants to go for dinner. Thank you very much for this opportunity to talk in this nice refractive symposium. Good night to all.
Thank you, Dr. Arvind. That was a very crisp talk and a lot of take-home points. Thanks a lot.
Thank you again for the very nice and clear and lucid presentation. And I take this. If there are any questions from the audience, we can answer, or we can go for. So, I request Dr. Chitra Ramurthy Madam to present the mementos to all the speakers here. So, yeah, please. I request Dr. Bhaskar Srinivasan to come and receive the memento. Okay.
I think we should all clap for the wonderful talk.
Dr. Kasinathan to come and receive the memento from Dr. Kasi now. Dr. Soundram, please come on to the dais to receive the memento. Dr. Nishant, please do come. Dr. Shreyas Ramurthy to the dais, please. Dr. Seema Prabhu, please come. Dr. Arvind Venkatraman. Photo, please. Yeah. Right. Yeah, yeah, yeah.
All the speakers, we'll take a photograph together. Speakers.
I request all the speakers to come for a photo. I take this opportunity to thank all the speakers for their excellent talk, and I hope all of you enjoyed, and thank you all for making this meet a really wonderful one. And I thank a special thanks to Care Group and Mr. Vipin sir for the wonderful cooperation, support, and seamless and hassle-free program has been possible with your support. And I thank Mr. Ratish and Mr. Saravanan, Mr. Caleb, and all the others in this team for this wonderful program. And I also thank our photographer Hari for the photography as well as videography and the live streaming that is happening. Thank you all for coming here, and I thank our support staff and support team who have been doing a wonderful job. Thank you very much. Thank you.